It is 9 o'clock, sorry, 8 o'clock. So, with the permission of the faculty, we warmly wish all the faculty for a happy new year 2021. And I think over the last 8 months, we have definitely grown in strength. And good evening, Kanna sir. Welcome, sir.
Good evening,
So,
sir. Happy New Year, sir.
Happy New Year, sir.
Happy New Year, sir.
So I'm also happy to share. We are touching 1,30,000 viewership so far, and we are inching towards 6,000 subscribership. We have crossed 5,750 as of now. So with that information, I wish all the participants and faculty a very happy New Year. And we pursue with today's case. We have two cases. One is from Vijay Medical College, Ahmedabad, by Dr. Rajan Patel, sir, student. Case of ischemic heart disease.
It is
ulcer disease. Yes, sir.
NHL Medical College. That is different. Municipal.
I'm sorry. I'm still getting.
No, it's okay. It's okay.
So NHL Medical College. And the other case is given by Tata Main Hospital from Jamshedpur by Dr. Debashish Pani. So I will keep second case as vascular because we wait for Sri Kumar sir also to join a little later after the COVID meeting which he's going through. So I warmly welcome the invited faculty, the professor and head of the department of KIMS Hubali, Professor Guru Shantapa sir. I cannot tell him as an invited, he's there with us with most of the classes. But then for formal reasons, we take him as invited faculty today. So with the permission of the faculty, Kanna sir, can we start, sir?
Yeah, please.
Yes, please. So we will have the oral cancer case from the Tata Main Hospital, Jamshedpur. We'll have Debashish Pani. Please switch on your video and start sharing the PowerPoint. I would request you to introduce your head of the department, your unit chief, and start your presentation, Debashish. And for your information, this case has been presented in one of the national forum beforehand, but this case is very informative and worth discussing again. So the candidate has informed sir that has been presented earlier. Then we said, as the case is very important, we agreed to go ahead with the presentation because it's quite some time we discussed the oral cancer. So with that information, Debashish, please share your screen and start your presentation.
Okay, thank you, sir. So, is it visible, sir, screen?
You are good to go, ma. Please start.
Okay. Good evening, everybody. My name is Dr. Debashish Pani, third year resident, Department of Surgery, Tata Main Hospital. My guide for this case was Dr. Jojo James, consultant, and HOD is Dr. Sridhar Pradhan, Tata Main Hospital. Coming to the case, Mr. X, a 55 years old Muslim gentleman, a shopkeeper, a resident of Azad Nagar, Jamshedpur, belonging to lower middle class, presented in our OPD with chief complaints of ulcer over the right lower lip for last 3 months, loosening of the lower incisor teeth for last 3 months, and pain over the ulcer for last 2 months. Coming to the present illness, history of present illness, he presented with an ulcer over the right lower lip for last 3 months, which was insidious in onset, initially small in size, as explained by the patient, a size of a pimple, which rapidly progressed to the present size, roughly of 4 × 3 centimeter. There was no history of any associated bleeding from the ulcer or any kind of discharge from the ulcer. Now, it was also associated with loosening of the teeth of the lower central and lateral incisors, and which uprooted spontaneously over these 3 months, and the ulcer has progressed over the gums of the uprooted teeth. It was associated with pain over the swelling for last 2 months, which was insidious in onset, continuous, and mild to moderate in intensity. There was no aggravating factors, but however, the pain was relieved on taking oral medications. there was no difficulty in opening of the mouth. He did not give any history of previous oral lesions previous to 3 months. There is no associated ear ache or excessive salivation or slurring of the speech. There is no history of any loss of sensation over the chin area. And there is no associated hemoptysis, cough, fever, loss of appetite or weight loss. There is no difficulty in swallowing or in breathing. Coming to the past history, he was a known hypothyroidism and taking tablet thyroxine 50 mcg daily, and but no other comorbidities like hypertension, diabetes mellitus, drug allergy, or any chronic comorbidities. There is no any history of surgical intervention except for in the treatment history. The patient was taking some oral medication for pain relief for last 1.5 months. The patient has undergone a biopsy from the lesion, and the patient had also undergone radiological investigations like CECT, head and neck, and chest, and MRI of the head and neck region. There is no significant family history. Coming to the personal history, the patient is a known consumer of tobacco in the form of he started taking honey at the age of 25 years, and since then he has been taking it for last 30 years. He used to consume it as a taking a pinch of it and in the form of a quid, keeping it in the right side gingival labial sulcus for long durations while working in the shop. And but he has left tobacco for last 3 months since the onset of this ulcer. He does not give any history of alcohol consumption, smoking, or any high risk behavior. Now, summarizing my history, a 55 years old hypothyroid gentleman presented with ulcerated growth over the right lower lip for last 3 months associated with loosening and spontaneous uprooting of the adjacent lower incisor teeth for last 3 months, pain over the ulcer for last 2 months, and with an history of tobacco intake in the form of kyanine for the last 30 years. Should I proceed, sir?
Devashish, you said it is the right lower lip. Is that correct? How many lower lips are there?
The right side of the lower lip.
It is the right side of the lower lip, no?
Yes, sir.
Okay, right. And do you think in this patient, the patient has complained of the ulcer in the lip and not in the gingiva?
So the patient's word was lip, sir, but I would expect it to start in the gingiva due to the history. But the patient repeatedly told me, sir, it started in my lip in the upper area, sir, and then it went on to
వేరే
the
జూమ్ కాన్ఫరెన్సెస్ ఉంటాయి కదా వాటి నుంచి సేమ్ కాదు జరుగుతుంది లైవ్ కేస్ ప్రెజెంటేషన్స్.
And where he used to keep the quid, you said, what was the exact site where he was keeping the quid?
Sir, right side of gingiva buccal sulcus, sir.
It's exactly at the same place
Yes,
where
sir.
the ulcer is, or it is different?
So the same place where the ulcer has developed, sir.
But can if he keeping at some other place, can he develop the ulcer at some other place?
Yes, sir. It can happen because field cancerization can happen in this kind of patient, sir. So there can be ulcer at different place.
Devashish, you mentioned that Mr. X, Muslim male, right? Nowadays, many examiners do not prefer to give identity of caste unless it is giving some extra incidence or that. So if you need to mention that in summary, then and then you mention. I do not have personally any issue with that, but many examiners interrupt you. So if you are beginning with Mr. X, and if there is no incidence in that caste or religion, then it is better to avoid. Just a suggestion, because the thing which you need to mention in summary, as far as this thing is concerned, that also only you mention. Just a suggestion.
Okay.
Yeah, Devashish.
Yes, sir.
Yeah, you said after having noticed the ulcer, he could notice that the teeth are getting loosened.
Yes, sir.
Okay, anything does it convey?
Sir, it gives information that the mandible might be involved by the ulcerative growth, sir, and that has led to the uprooting of the tooth.
Why involvement of the mandible in oral malignancies causes loosening of the tooth?
Not sure, sir.
Okay, if you do the imaging in such cases, if you think that this is the impression, if you do imaging in such cases, will the imaging show bony involvement in all the cases?
No, no, sir.
May not. May not.
Sir. May not.
So it is a gingival involvement, socket involvement, not necessarily the mandible.
Okay.
Not necessarily the mandible. In other words, there is a dictum in a middle-aged patient with all that habits. If he has come with a oral ulcer, non-healing ulcer, and if he gives a history of loosening of the teeth, it is malignancy unless otherwise proved. So it is a socket involvement. It is a gingiva involvement, not necessarily a mandibular involvement. Okay. And in the summary, you mentioned that in case of hypothyroid, he is not hypothyroid now. He is already on treatment. So I don't see any justification of in the summary putting that he's a 55 years hypothyroid male. There is no justification. Okay, so he is already, you have elicited the history that he is on drugs for hypothyroidism. Maybe if you evaluate biochemically, he may be euthyroid, or clinically he will be euthyroid. So don't highlight that he is a hypothyroid male, because in the history, no symptomatology you have mentioned in relation with the hypothyroidism.
Yes.
Okay, and oral malignancy is no way has got any connection with hypothyroidism. So highlighting this hypothyroid male, I felt it is not a justifiable presentation. Okay, and you said there is no history of discharge. If an ulcer is over a lip where there is a continuous salivary secretion, how can you say that there is no discharge from the ulcer?
Apart from saliva, sir, I could not notice any kind of discharge.
Can you differentiate? Can you differentiate in the history that it is a saliva or it is a discharge from the ulcer? Can you differentiate?
So if there is an obvious...
So best way is, whenever you are presenting a case of ulcer over the mucosa of the oral cavity, don't mention this point. The point to be highlighted is if he has got an excessive salivation. Okay, that is a point to be highlighted. No discharge, you have mentioned somewhere, no discharge in the presentation. Am I right?
Yes, sir.
So that is not required. And second, since the lesion he has presented is in the one side of the, like Khanna sir mentioned, no, how many lower lips. So it is a right side of the lower lip. So if there is a history that it is one side of the lower lip, the immediately you should find out whether he has got any dribbling of the saliva from that side of the mouth.
No, sir.
What is the importance of this history? Yeah, if I insist that you should ask. If that is a case, what is the significance?
If there is dribbling of saliva from any side of the mouth, it signifies the tumor has infiltrated the facial nerve, leading to some kind of facial nerve palsy.
Facial nerve. Why facial nerve infiltration should cause? Is it a facial nerve involvement or something else? What is required?
In the law?
What is required to prevent a dribbling of saliva from the angle side? What is required? It is otherwise, what is it? No. It is otherwise what? If somebody says dribbling of saliva, what does it mean?
There is a restriction in mouth closing.
No, not restriction. It is a oral incontinence. Like how you have got a anal incontinence, it's a oral incontinence. So if I say it is a oral incontinence for a dribbling of saliva, what should be the disease or what should be the pathology in this particular case?
So excessive salivation is...
That is excessive salivation. I am talking about ulcer situated in one side of the lower lip. means we don't know. Examination will come to know that it is involving the commissure, angle of the mouth.
Okay,
So
sir.
probably it is infiltrating or the sphincter, oral sphincter, that is orbicularis
Oris.
orbicularis oris. So indirectly it says that probably that muscle is infiltrated by this malignant ulcer if that history is there. See, these points, we are almost staging the disease. We are diagnosing and staging the diseases. That is why we need to have some important symptomatology whenever we take the history. Okay? Fine.
Okay, sir.
Fine. Sir, Hitesh, sir, can you go to general physical examination?
Yes, sir. Yes, sir.
Okay, sir.
Coming to the general examination, a patient was examined in a well-lit room after proper consent in the sitting position. He was alert, conscious, and cooperative, oriented with respect to time, place, and person. He had an average build, well-nourished, tongue was moist, ECOG score of 0, height was 174 centimeter, weight was 69 kg, BMI of 22.8 kg per meter square. His pulse rate was 86 per minute over the right radial artery, normovolumic, regular in rhythm. His blood pressure was 120/76 millimeter of mercury in the right brachial artery in the sitting position. And his respiratory rate was 14 per minute, regular in rhythm. Temperature, he was afebrile. He did not have pallor, icterus, cyanosis, clubbing, pedal edema. However, the neck nodes of right side level 1 and 2 were palpable, the details of which are given later. So here is the photograph of the patient.
Yeah, one second. Before you go to general physical examination, I will give a scenario for this gentleman. Okay,
Yes.
you are in the OPD, the same gentleman comes, but when he is sitting, he is at a distance. When you see him, he looks tachypneic, he has got a hurried breathing, he looks toxic, and he is coughing repeatedly. Okay, same patient. So before you start examining local examination, what is that you will keep in your head? He looks tachypneic. When you examine pulse, it is 110 plus. He looks little febrile. And he is now and then he is coughing out.
It can be an tubercular ulcer, sir.
Oh, tubercular. Is it common having ulcers in the oral cavity secondary to tuberculosis?
No, sir, it is not common.
So?
The posterior third of the tongue might be involved, which is causing respiratory distress and oropharyngeal.
This lower lip lesion going all along and then involving the posterior 1/3 tongue and patient is alive, is it a possibility? Because he has come with a lip ulcer.
Yes.
Yeah, so ultimately, if this scenario, what I am giving, what is that system involvement you are thinking in terms of? Which system?
Respiratory system. Yeah.
Respiratory. Now you tell me what is the relation between oral malignancies and respiratory system involvement other than metastatic deposits?
Don't know, sir.
You come out of oncology department, no? For the time being, just come out of oncology department. You enter some medicine department, some other departments. What is common? What is a medical disease common in oral malignancies or tongue malignancies? What is common? They will have aspiration. Aspiration is very common.
Aspiration, yes, aspiration.
More in the night. So they may develop aspiration, pneumonia, or chest infection. In fact, sometimes they may present to a physician. Because of their respiratory problem. Okay?
Yes,
yeah,
sir.
Please. Yeah, go ahead.
Sir, other picture, sir. Okay, coming to the examination of the oral cavity, there are no visible asymmetry of the face and deviation of angle of the mouth seen. Then mouth opening was adequate, that is more than 3 centimeters. The teeth were stained, oral hygiene was poor, and halitosis was present. Lower central and lateral incisors are absent, and ulcerated growth present over the lower lip extending to the gingival sulcus, majority of it towards the right side, irregular in shape, size roughly 4x3 centimeter, margins are irregular with everted edges. Ulcer extends from the mucocutaneous junction of the lower lip anteriorly to the alveolar ridge posteriorly. And right side it extends about 3.5 centimeter from the midline laterally and in the posterior aspect up to the right canine teeth. On the left side it is 0.5 centimeter towards the left lateral from the midline anteriorly and left canine teeth posteriorly. The floor of the ulcer is covered with a grayish white growth and with no fissuring, and lower gingival labial sulcus was covered by the ulcer. The tongue, floor of the mouth, cheek, mucosa, and facial pillars and oropharynx were normal. On mouth opening, no palatopharyngeal fold restriction in movement was seen. Tongue protrusion, retraction, elevation, and depression movements were normal. On palpation, the inspectory findings were confirmed. The ulcerative growth was tender and firm in consistency. It was size of 4 × 3 centimeter. There was an induration all around of about 0.5 centimeter. It did not bleed on touch. The retromolar trigon and the floor of the mouth was free. On bimanual palpation of the mandible, no other teeth were loose at the time of examination. No specific crepitus over the mandible underlying the ulcerative growth could be appreciated. Now coming to the examination of the neck, on the right side, level 1A, 1B, and 2 lymph nodes were palpable. Largest was of 1 × 1 centimeter. They were hard, non-tender, and mobile. On the left side, there were no palpable lymph nodes. Bilateral carotid pulse could be palpable in the, and the movement of the temporomandibular joint was normal. The cervical spine examination was normal. Here are some other pictures. The tongue movements are normal, sir. And systemic examination within normal limits. And coming to the summary, a 55 years old gentleman presented with ulcerated growth over the right lower lip for last 3 months, associated with loosening and spontaneous uprooting of the adjacent lower incisor teeth for last 3 months, associated pain over the ulcer for last 2 months, giving history of tobacco in the form of kyanine intake for last 30 years, a grayish white ulcerative lesion of 4 × 3 centimeter involving the right and extending beyond the midline of the lower lip and gingival labial sulcus, which was tender and with everted edges. The right submental, submandibular, and upper jugular lymph nodes are palpable. Hence, my provisional diagnosis is a 55 years old.
Yeah,
gentleman.
we will wait. Hold on. We'll come to the diagnosis maybe a little while. Put back your inspectory finding slide or a photograph, clinical, whatever, previous slides. Okay, fine. How did you want to describe this as an ulcer? Okay.
Yes, sir.
Okay. How many incisor we have?
We have the 4 incisors, sir.
No, you talk about lower jaw. We'll stick to the area where the disease is. Huh? How many incisors?
4 incisors in the lower jaw, sir.
Okay.
2 central,
Okay.
2 lateral.
Okay. Yeah, 2 on the right side, 2 on the left side. Okay. And you said what is the medial inner extent of the ulcer?
Sir, extent is, sir, from the midline, sir, on the right side laterally up to the
inner extent. First describe inner extent, because see, describing the extent in a oral ulcer is really important clinical examination finding. Accordingly, you will have a palpatory
up
finding.
to this alveolar ridge, sir. The inner extent is up to this alveolar ridge, sir.
Okay. See, in this case, because he has lost his the incisors, that is why you are taking alveolar ridge as a point. If tooth would have been there, you will be mentioning it as a alveolus. Okay, that is a point what I wanted to highlight, because in this particular case there are no tooth. Okay, yeah, fine. 1.
And sir, anteriorly, sir, this is the extent, sir, the mucocutaneous junction. This whole thing, sir.
Okay.
And sir, laterally, anteriorly, it is roughly from the midline.
Fine. That you have described. You said mouth opening is 3 centimeter. You think that 3 centimeter is normal or abnormal? You have written 3 centimeters.
Sir, it was more than 3 centimeters, sir. It is normal, sir, because ideally I would prefer the distance between 2 incisors, sir. As the lower incisors are absent, sir, I cannot get that exact distance. But it was well more than 3 centimeters, sir. So that's why I've told it to be adequate.
Okay, it is 4 and above 4 is normal. Okay, and you
sir.
go on deducting 1 centimeter, then that becomes the grading. Otherwise, what is the best way of assessing with the patient's hand? Adequate
Sir,
mouth opening.
more than 3 fingers, sir.
How he should be keeping? Just show in the video itself. Yeah, fine. Okay, so that is how we assess. Any other way of assessing the adequate mouth opening? Any other system you know?
Sir, 2 systems, sir. One by the patient's hand, sir, 3 fingers, 2 fingers, 1 finger. And other is by measuring from incisor to incisor. If it is greater than 35 centimeter, it is grade 4. 25 to 35 centimeters, grade 3. Then 15 to 25 is grade 2, grade 3. Then less than 15 is grade 4.
Any other way other than these two, where you are actively involved?
Not centimeters, it is millimeters.
Millimeters.
Yes, sir, millimeters, sir. No, sir.
Just looking at the opening, you will be able to assess what is adequacy of mouth opening, depending on what are the structures seen once he opens the mouth.
Sir, Malam patti, no.
So what is that? You will be whether see in this case, for example, keeping the tongue inside if he opens, because he has protruded tongue out, everything looks obliterated here. Keeping the tongue inside if he opens, so if you are able to see the tonsillar fascial pillars and the postpharyngeal wall, that is normal. Okay. So from there you come anteriorly, whether only soft palate is seen, only hard palate is seen. So depending on that, we grade. Okay.
Okay.
It will be asked in the examination. Once you get an oral malignancy, it will be asked. Why it is important to know whether he has got adequate mouth opening or not? What does it give inference?
Sir, if there is involvement of the masseter muscle, sir, by the tumor or the pterygoid muscles, there will be inadequacy in the opening of the mouth, sir.
Which is more common in oral malignancy? Is it involvement of pterygoids or is it involvement of masseter resulting in trismus? Which is more common?
Masseter will be more common, sir.
Oral malignancy is masseter. How often it causes trismus? It's a pterygoid involvement. Okay, it's a pterygoid involvement which. Sir Hitesh, you accept this or?
I have rarely involved in oral cancers until as the buccal has gone into the mandibles. The masseters are lying outside the mandibles, so masseters are not involved usually.
Yes. Okay. Fine. Yeah. Continue.
It's a retromolar trigon with the pterygoids.
I have one question, Debashish.
Yes,
what did you describe this basic lesion as actually? This lesion.
Repeat, sir.
This lesion, whatever I am seeing now in this picture, how did you actually describe it as what?
An ulcerative growth, sir.
And I just wanted 1 or 2 questions to you. What is the so much whitish thing there? Did you ever mention in the inspection? Did you mention about that? Is it common thing?
Sir,
Yeah, please go ahead.
Sir, I mentioned the floor was covered with an whitish.
Is it only the floor? Look at that lesion, which is extensive. I just wanted to know what are those important pre-malignant lesions? Yeah, what somebody is showing that in that cursor there. What is chronic hyperplastic candidiasis and leukoplekic patches? What's the difference in the palpation wise? Did you mention about palpation of these lesions?
Yes, sir.
Because ulceroproliferative means we should really see one, like a cauliflower-like lesions. I'm not able to see in this picture whatever you have shown. I don't know whether you have any other pictures. I'm not sure about that. When this happens right on the periosteum, see, patient has lost the incisor teeth, correct?
Yes, sir.
So that means what? Where do you think the lesion probably is? Almost close, very close to the bone edge there. You know, means
sir.
with the floor of the mouth involvement there. So
No, sir.
when you yeah, please go
It
ahead.
is
Go ahead.
sir, the lesion is up to the alveolus only. I have checked the floor of mouth is not involved in the.
How can it be? It is in the alveolus, and the other side we are seeing up to the tip of the almost that lip, everted lip there, and how do you say in between it is normal? You understood?
No, no, sir, not in between, sir. I'm not telling the floor of the mouth is not involved. Below the tongue, it is not there.
Okay, my point is that the lesion does not look like classical ulceroproliferative growth. That's what I am trying to tell. It's right on the bone. I can see that the edge is a little bit elevated, that everted there. Rest is the large area for me. It is looking like a leukoplakic patch or a hyperplastic, candidias like a lesion, large premalignant lesion. And palpation wise, whether there's an indulation or not, that is what in this area, not in that red area where we are seeing on the alveolus.
Rajgopal, sir?
Yes, yes.
Right. It could be that there is hyperkeratosis with ulcer proliferative with the saliva swirling around. That the hyperkeratotic patch has become white because of proliferation. So it could be like that. Okay, Debashis, I'd just like to ask you one question. Falling of which tooth is important in a patient when you take history? Which tooth?
Sir, falling of the canine tooth is important, sir.
Why is that?
So because the inferior alveolar nerve passes to the canine fossa, which is just below the canine tooth, sir.
No, the canine teeth, the fossa, canine fossa, is the deepest. That's why when you get a fracture of the jaw, of the lower jaw, it usually happens at the canine socket. So this it becomes very close to the medullary canal. So involvement of medullary canal can be early if then the canines are fallen. Right? And next would be incisors. So I have not heard your history. Is there any difficulty in swallowing in speech? Increased salivation?
No, sir, there is no difficulty. No, sir, there is no history of any increased salivation or difficulty in speech or swallowing, sir.
Protrusion of tongue is normal.
Protrusion of the tongue is normal, sir.
Okay. No history of earache?
No, sir, no history of earache, sir.
So please carry on. Should we go to examination, sir?
He has completed, sir. He has completed the local examination and
please continue, sir. Then.
And the neck examination. You said something about the bimanual examination. What is that you mentioned about digital examination in this case? You mentioned.
Sir, I wanted to. Yes, sir. Yes, sir. Yeah, in this area. Sir, I wanted to check for any other loose teeth there to find out any other adjacent teeth as involved or not, the adjacent canines. And I wanted to check whether any pathological fracture of that bone was there or not. So that's why I was trying to elicit any crepitus underlying the ulcer was there or not.
So these 2 points, that is doing it is not bimanual, it is bidigital. So doing this bidigital palpation for loosening of the tooth, I don't know what exactly you want to mean. And second, is it the crepitus which you will look for the involvement of the mandible? It is not a fracture, no, they will have. It is not the fracture where you will elicit the crepitus. So what is that word you would like to use for these 2 things? When do you do bidigital examination in an oral malignancy? It is not for finding out loosened tooth, no.
Not sure, sir.
Okay. In this particular case, actually bidigital examination is not required because it is obviously seen outside. It is involving the lower lip. So you have to just check for the induration by examining the by the side of the ulcer, that is ulcer margin. And second, crepitus you should not. How do you examine for the mandible to know whether malignancy is involving the mandible? How will you examine clinically?
Sir, if the growth is not fixed to the mandible, sir, that fixity, that is.
If it is a gingival or sulcus involvement, you cannot know. You will be. So there you need to do bidistal examination, keeping one finger in the floor mouth, one finger in the sulcus, lower sulcus, gingivobuccal sulcus, and pass those two fingers from posterior to anterior. If there is an involvement in the form of expansion, your fingers will go away at the site of expansion involvement in the mandible. Or if it is in the form of erosion or infiltration where there is a fracture, you'll be able to feel the step deformity there when you do a bidistal examination there. One outside, one inside. Okay, it is not for loosening of the tooth, bidistal examination.
Okay, I would like to ask one thing. We've spoken about mouth opening. So I was talking about mouth opening. What are the causes of decreased mouth? You said one is trismus. Any other cause of decreased mouth opening?
If there is associated oral submucosal fibrosis, sir, right, that can cause.
SMF is a very important cause because in the patients who chew this kind of tobacco, there is a lot of, especially in Asians, there's a lot of submucous fibrosis, and that also leads to decrease. There's trismus, there's involvement of the TM joint, and then there is
oral submucosal fibrosis.
Is there any pain in the ulcer?
So tenderness is there, sir. Pain is also there, sir. Yes.
So why do you think it's painful? What could be the cause of pain? Are malignancies painful?
No, sir.
Then why is this painful then?
Sir, the involvement of the underlying nerve might be there, sir.
Which nerve?
Inferior alveolar nerve, sir.
Inferior alveolar nerve?
No,
sir. Okay, then suppose that nerve is where will the pain go?
Sir, it should be referred to the auriculotemporal region, sir. Ear and temporal region. Lingual.
Usually referred to the ear. Any other cause of pain? More common? You can see in this patient that this could be the cause of pain. Infection.
Infection of that.
Infection is a very common, right? It's very common. Okay. Did you talk about any fetor, oral fetor, any smell?
Yes, sir. Halitosis is there, sir. Smell is there.
So why do you think there is halitosis in these patients?
Sir, the patient has a bad oral hygiene, sir.
Oral hygiene, so what? Then? Why should there be halitosis? What are the causes of halitosis?
Sir,
just spoke about
infection of that area. That
there is
causing
infection.
halitosis.
There is decaying food material which is stuck into the ulcers. So there's halitosis because of decaying of food particles. Any cough? Any fever?
No, sir. No cough, no fever.
Why would you like to ask for cough or fever or anything? What could be? Why would you like to ask for that?
Sir, one reason is, sir, as sir told, due to there might be aspiration pneumonia, sir.
Right, bronchopneumonia. And what would that cause?
That would cause pneumonitis, fever, cough, tachypnea, tachycardia.
Lung abscesses. Lung abscesses can be.
Debashish, which is the most painful ulcerative lesion in the mouth?
Aphthous ulcer, sir.
Very good. Okay, fine.
Okay, another question now. It's not involving the flora of the mouth. Which are the most common sites for oral cavity ulcer, and why? Any reason for it?
Sir, in Indian scenario, sir, gingivobuccal sulcus is one of the common reason.
Why is that? Why is that?
Because of the habit of keeping a quid in that sulcus area.
So usually at the local site where there is irritation, right?
Yes, sir.
And if that is not there, then
sir, then there is if the patient is a smoker, sir, the upper part of the lip and dorsum of the tongues are involved. And if sharp tooths are there, then lateral aspect of the tongue are more.
What is the percentage? If you go by percentage, what is the percentage in oral cavity?
Percentage, sir, I don't know.
You don't
or
remember?
at least tell no number 1, 2, 3 in order of preference. Tell the sites. Number 1, oh yeah, most.
Number
common.
1
Second.
will be in Indian scenario, sir. Number 1 will be gingivobuccal sulcus. Then will be the lateral aspect of the tongue. Then the tip and anterior aspect and tip and dorsum of the anterior 2/3 of the tongue. Then the posterior 2/3 of the tongue.
Posterior 2/3 is gone. What about floor of mouth? Buccal.
What about gingiva?
Gingival.
Gingiva. Where do you keep them?
Common.
Yeah.
Right.
Yes, sir. After tongue, sir. Then.
Look, you got to get your facts correct, right? Which is the according to how common what is. So floor of the mouth is quite common. Now, why do you think that is quite common?
Sir, due to the all this carcinogenic saliva pooling in the floor of the mouth, sir.
So one is pooling, and what is the other reason for it? Is the lining different from elsewhere? The mucosal lining, the thickness of the mucosal lining?
Not sure.
Right. The mucosal lining is less. It's less thick here, right?
Okay, sir.
It's non-keratinized here. So the chances of it. So he takes tobacco. Now, why is tobacco? What is tobacco? Does it take alcohol also?
No, sir. He doesn't consume alcohol.
Okay. So why is tobacco so important?
Sir, because tobacco has many carcinogens, out of which it is acted upon by the oral bacteria to form a compound nitrosamine, which prevents the DNA damage repair in the oral mucosa, causing the carcinoma. It is acts as a carcinogen.
Okay. So suppose he stops smoking. After how long will the risk fully abate?
Sir, if it's an leukoplakic patch, sir, then usually after 1 year, about 60 to 70% of the patients are seen it is fully abated.
After how many years? No, I'm saying smoking. We're not talking leukoplakic patches.
Smoking.
Almost 10 years, it's 50% chance. Okay. Okay, what are pre-malignant conditions? What are risk factors and what are pre-malignant conditions? What is the difference between them? What are the risk factors for oral cancer and what are the pre-malignant conditions for oral cancer?
Sir, risk factors is anything that can lead to these cancers, like deficiencies, various kind of deficiencies, as well as all the precancerous lesions and pre-malignant conditions.
No.
Pre-malignant.
What do you mean by risk factor? What do you mean by pre-malignant condition?
So pre-malignant conditions involve the syphilitic patches, oral submucosal fibrosis, and sideropenic anemia. Whereas risk factors can be.
No. Go on. The only 4 risk pre-malignant conditions for oral cancer. Go on.
Pre-malignant conditions: leukoplakia, erythroplakia, melanoplakia, and chronic hyperplastic candidiasis.
Where have you gotten this from? It is leukoplakia, erythroplakia, lichen planus, and submucous fibrosis. These are the only 4 conditions, right? And what are the risk factors?
So, the risk factors can be sideropenic anemia and syphilitic ulcers, tubercular ulcers, and
you started off. It's alcohol, smoking, which is the most common.
Alcohol, yes, sir. Smoking, spirit, alcohol, spices.
Look.
Sir, if you ask him what are the 5 yes, he will tell all yes.
No, it's
all
not
5
like
yeses.
Hey, look, you have to go according to what? You take in smoking, you take in alcohol, you take in oral hygiene. So these are the major risk factors there. All others are, then of course all those sharp teeth and all that comes, right? So you must come up with the most important ones first, right?
Okay, sir.
Then comes salted and all that red meat. And what about HPV? Any role of HPV?
Yes, sir. Human papillomavirus is a risk factor for oral carcinoma, sir.
Is it? In IJCC 8,
Yes, sir.
they've removed.
Is it for all oral malignancies or only specific oral malignancy they contribute HPV?
Sir, now it has been divided into HPV related and non-HPV related oral malignancies.
Right. So which is that oral malignancy? Which malignancy? Oral malignancy. Does buccal mucosa is related to HPV?
No, sir. The verrucous malignancies are related to HPV.
We'll give option. Is it buccal mucosa, gingiva, tongue, floor mouth? In association with HPV infection. Yeah, fine. I think you should you should know this. Like sir said, not like every case will have a HPV. Only one of these four. One of these four. Fine.
Okay. So what do you mean by leukoplakia? You said leukoplakia. What do you mean by leukoplakia?
Sir, whitish plaque which cannot be pathologically or clinically classified into any kind of disease is known as leukoplakia.
Any more characters which cannot be rubbed off and more than 5 millimeters in size. Okay.
Okay.
And okay, that's theory now. How do you manage this patient now?
Sir, my provisional diagnosis was a 55-year-old gentleman suffering from a primary ulcerative growth over the right lower lip and gingival labial sulcus, probably of malignant etiology with right-sided level 1 and 2 palpable neck lymph nodes, clinically T4A, N2B, and MX disease, sir. Sir, now I would like to do investigations to confirm my diagnosis, to stage my disease, and then to treat the patient, sir. Sir, for confirming my diagnosis, I would like to do an wedge biopsy of that lesion, sir. And for staging of the disease, sir, I would like to do an CECT of the head and neck region, sir. And for
No. First, what you said you do to confirm you do a biopsy, okay. And to any other investigation before you do a CCT?
Sir, I would like to do also an USG of the neck, sir, to further.
So why get a USG of the neck first? Anything else?
Sir, a few office procedures also I would like to do, sir, like indirect laryngoscopy, sir, and to see any base of the tongue involvement is there or not, sir.
What about an X-ray, plain X-ray of the mandible, or an OPG? Anything, any role of OPG or plain X-ray of the? Why won't you do a plain X-ray of the mandible? Would you like to do one?
Sir, as per guidelines, sir, CECT will give all the information given by the orthopantomogram.
Why not? Then why not? What are the indications for doing a CECT and what are indications doing an MRI? Why not an MRI?
Sir, MRI would like to do, sir, if we want to confirm the involvement of the marrow involvement of the mandible, sir. Cortical involvement can be seen in the CECT, sir. And
okay, one is bone and marrow. Okay, what else?
Sir, MRI also will give better information about the soft tissue extent involvement.
Soft tissue. What else?
And nerve involvement will be better seen in MRI.
So
sir.
Three things: soft tissue, nerve, and marrow. This is for MRI. What about CT?
Yes, so CT will show us first the involvement of the mandible, And
Bony cortex.
also it will show
Bony
about the
cortex.
nodal status.
Be specific. Be
Bony,
specific.
bony cortex, yes.
And
Bony cortex. Then it will also give information about the lymph node involvement in the neck and
neck nodes.
neck nodes. And also, sir, if there is a carrot, if
Nowadays
you do
in this AGCC8, one thing has come up. There's one term for it.
Extranodal extension. Extranodal extension.
For that, you need a
of
CT
the lymph nodes.
Right. So that is
Yes,
important. Can you find out if the lymph node has got extranodal spread clinically?
Sir, clinically, sir, if it is an matted or fixed nodes, then we can tell it is an extranodal involvement.
Okay, so when it's fixed to the surrounding tissue, then you know that there is.
Yes, sir. Right. Extranodal extension.
Any role for PET scan?
Sir, it is not recommended, sir, but in a very advanced lesion, suppose it is T4B or T4A advanced lesion, when if it is an irresectable lesion, sir. When it is an irresectable lesion, then few MDTs they advise to go for a PET CT to have a pre-chemo status
for a pre-adjuvant therapy. We get one.
Pre-adjuvant therapy, they want a PET CT, sir. But as per se, there is guideline doesn't recommend a PET CT for in every case.
Okay, so you've done a wedge biopsy. What do you look for in a wedge biopsy?
Sir, what is that type of malignancy, sir? Whether it is an squamous cell carcinoma or
pathological type.
any.
What else?
Sir, also we look for the depth of the invasion, sir, pathologically.
Depth of invasion. What else?
In oral malignancy, if you take a biopsy, will it tell us like a depth, like in melanomas? Is it really going to matter you, or is it something different you want from the biopsy specimen, from the pathologist? Is that depth involvement, does it really matter for oral cancers? Like in melanoma, you know,
Sir,
in melanoma.
Depth, sir, in staging, sir, it is required, sir, less than 5 millimeter or more than 5 millimeter, or up to more than 10 millimeter.
AGCC8 has included depth, right? Has included depth.
Yes, sir. Yes, sir.
What are all the details you need in a biopsy specimen so that it will help you for further treatment modalities? What are the information you want from the biopsy?
You told me about the pathological type. You told me about the depth. Now, what else do you look for in? Very important. Grade?
Grade.
Right. Grade is also important here, right? So you look for the grade of the tumor. So how do you, what is the TNM classification here? Sorry, sir. TNM staging in this patient?
Sir, T4A, N2B, MX at present, sir.
T4A?
A, sir. Yes, sir.
Why do you say T4A? Why is T4A?
Sir, T4A, because of the lesion is 4 centimeter and it is having
T4 doesn't have size. Sorry, T4 doesn't have size.
Yes, sir.
Doesn't have
size.
Sir,
I am suspecting involvement of the mandible, sir, because as there is uprooting of the tooth and it is very close by. So that's why local invasion comes as T4A, sir, and it is resectable. That's why A. If it has been irresectable, then it will be T4B, sir.
Okay. So what do you mean by advanced disease?
When, sir, the disease is irresectable, it is advanced disease, sir. That means it has.
I mean, it might be irresectable for you. It might be not irresectable for Dr. Andharia. So how do you know it's irresectable?
Sir, when there is involvement of the pterygoid base of the skull and encasement of the carotid artery, sir. And
Okay, encasement of carotid artery was 1. What else? Pterygoid is 2. Base of skull is 3. What else? What else? There are more things.
masseter.
Masseter, okay, what else?
Temporomandibular joint.
He just said medullary bone. Medullary bone.
Yes, medullary
What
bone.
else?
It is not only clinical what sir is asking, it includes the imaging findings also.
Findings also.
Metastasis.
Imaging, not M1 disease, not M1 disease. The regional or a loco-regional disease on imaging also will make this disease 4B or a locally advanced or advanced disease. So what else other than what all you mentioned? See, when these questions are asked, you take primary tumor first. You describe all extent of the primary tumor so that becomes 4B, inoperable. Then take the regional disease, where all it is going, put together and then give the answer. So other than this, other than this, on CT, when the CT is being done, how the CT, the involvement of the primary tumor on CT is classified on CT? If you do a CT scan for oral malignancies, how are they classified to say whether it is the inoperable or advanced disease or a surgically treatable disease?
Sir, in CT, sir, will look, sir, for these involvements, sir, are there or not, we can see, sir. If it is not there, or if it is, we can get a 1 centimeter margin from these structures, then we can.
No, it is not the distance from the tumor margin. It is the structures which are depicted on CT, which are involved by the disease, like pterygoid plates, which you have mentioned. Whether disease is extending above the notch, that is condyloid and coronoid process, which you have got in the mandible, there is a notch between those two. So whether the disease process is going beyond that, whether it is above supra-notch disease or an infra-notch disease. Always infra-notch diseases on CT imaging are surgically treatable diseases. Supra-notch disease, non-surgical diseases. Okay, then once there is a supra-notch disease, that almost it goes into the skull-based disease on CT, skull-based disease. Okay, or a temporal disease, temporal fossa disease. You said MRI, sir asked, no, what is the advantage of doing MRI over CT? Any particular indications for doing MRI in head and neck or oral malignancies? Oral malignancies?
Sir, if you want to see for marrow involvement of the mandible.
One. Any other particular disease where MRI overtakes than CT scan?
Sir, in tongue malignancy, sir, MRI.
Very good. Tongue malignancies. Tongue malignancy.
Then, sir, any nerve involvement?
Yeah, nerve involvement. When you are suspecting a nerve involvement, how do you identify on MRI? How evidences that the nerve is involved?
Sir, the planes in between the nerve sheath and the adjacent tissue is lost, sir.
Okay, fat planes around the nerve. Fat planes around the nerve. And second, the nerve where it enters into the bone. That foramina will be widened foramina.
Yes, sir. Widened.
This entity is called, in fact, it is not the involvement, it is called a spread, perineural spread of the tumor. That is done by imaging. What is now neural infiltration? Or are they same? Both are the same?
No, sir. Not sure, sir.
Okay. Perineural spread is an imaging finding, macroscopic finding, which is seen on imaging. Infiltration is a microscopic finding, which is reported by pathologist. Okay, either in the specimen or in the biopsy. Two different entities. Okay, what you would like to do for him now? Clinically, do you think the nodes are involved?
Yes,
metastatic
sir,
nodes? They are metastatic nodes clinically?
Clinically, sir, I think they are metastatic nodes, sir, because in presence of a primary, until and unless proven, they are metastatic nodes. Sir.
Why the infection and involvement of node is not common in oral malignancies?
Yes, sir, it can occur, sir. But at that, on presentation, he didn't give any signs of different fever.
So
or,
what is that investigation you will be asking to know whether they are metastatic nodes or not, which you did not mention? Halfway you mentioned and left.
Sir, I can ask for an ultrasound of the neck to see for whether the lymph nodes are malignant or benign, sir.
You don't want to do FNAC, USG guided FNAC of those nodes?
Sir, USG guided FNAC, sir, can be done, sir, but
why can be? You will prove it, no? You will prove it on histology, yes, on cytology by doing a FNAC. What prevents you to do FNAC? It has to be done. Just imaging, telling metastatic or not will not be accepted. You have to prove that, yes, there are malignant cells in the node. Okay. Does it make really difference for your treatment?
No, sir. Whether they come out to be malignant or not, then I will be planning a definite lymph node excision, sir. That's why it will not change my treatment.
Excision?
Sir, modified radical neck dissection, sir.
Yeah, it matters. Whether they are positive or not, it really matters for the plan of treatment. It matters. It matters.
Okay, sir.
Okay. What is the way the CT is done in oral malignancies? Any particular way? Any specific terminology when CT is asked?
Sir, contrast and CT with a bone sequence, sir, separate.
Agreed. What is the? What should be the patient doing when the CT, when he goes into the CT machine?
Extension.
He should go inside the machine with a closed mouth or with an open mouth.
Just think, this is in a soft tissue where there can we want the tissue to be expanded so we can delineate all the layers, isn't it?
Okay, sir.
So what would you like the patient to be doing? No, puffed cheek.
Open mouth.
Ask him for a puffed cheek.
Okay, sir.
Puffed cheek. So what's the stage?
Sir, stage 4 disease, sir. Now.
Why would you say stage 4?
4A, sir, because sir, T4A, N2B, M.
You said
0 or
there is bone involvement.
Yes, sir.
How are you sure about bone involvement? Are we talking clinically?
Yes, sir, clinically, sir.
How do you know there's bone involvement?
Sir, after the appearance of the ulcer, sir, the 4 incisors have fallen and it has been there for 3 months.
So what?
So
what? There could be just superficial erosion of the bone. That's not taken as 4A. As well. So you cannot comment. You think it's probably 4A, but you cannot be sure about it. Right?
Okay. So, yes, sir.
So is there any difference in treatment if there is bone is involved and not involved? Suppose there is a superficial erosion of the bone, and suppose there is medullary cavity involvement. Will there be a difference in treatment in surgery?
Sir, only if the cortical part is there, I can think of a marginal mandibulectomy, sir.
Very good.
But marrow is involved, then I have to go for a segmental resection, sir.
So what's the difference between the two in outcome? What is as a surgeon, how will you be concerned that it's marginal or
reconstruction for an segmental mandibulectomy would be difficult. I have to do a bone or a bone reconstruction also. For marginal, I can only do a soft tissue reconstruction, sir.
Very good. So you will not require any prosthesis to reconstruct the mandible, right? Very nice.
Yes, sir.
Okay.
If your plan.
Sir, you are muted, sir.
No, Hiteshwari Patel.
If your plan is to do marginal mandibulectomy, you're able to hear? Okay.
Yes, sir.
On imaging, what should be the minimum, the length of the mandible from the lower margin, so that that becomes a candidate for marginal mandibulectomy?
Don't know, sir.
Okay, so it should be minimum of 1 centimeter from the lower margin. Okay, that is one indication. The other indication which sir was asking, no, that is called the tumor is going up to the periosteum. It is approaching but not involving. It is approaching but not involving the bone. That is the indication for doing a marginal mandibulectomy. Once you say on imaging, it is infiltration or involvement of the mandible in any form, if you are fitting the second criteria of having a 1 centimeter of both the cortex of the mandible from the lower border, if it is absolutely normal on imaging, on radiologically, then that becomes a second indication for doing a marginal mandibulectomy.
And for segmental mandibulectomy, what are the indications?
Sir, if there is a marrow involvement is there, and then we have to do any segmental mandibulectomy.
I'm talking
sir.
clinically.
Then,
Clinically. Or there's segmental involvement. There's gross involvement of the mandible. You can see that the mandible is distorted. Or if you find that the tumor is fixed to the, if you on the occlusive portion of the mandible, of the edentulous mandible, if the tumor has reached the occlusive portion, that means you will take it as segmental mandibulectomy will be required.
Mandibulectomy.
And if the tumor is fixed to the mandible, you can't move the tumor at all from the mandible.
Then also we have to go to segmental.
If MRI says that there is a mental foramina involvement, the tumor is infiltrating into the mental foramen. So what may be the ideal way of treating?
Sir, if the mental foramina is involved, sir, then we have to do a segmental resection, sir. Segmental mandibulectomy.
In other words, even if the other part of the bone is normal, if there is a perineural spread into the mental foramina, it amounts to mandibular involvement. That is why the involvement of mental foramina on imaging is one of the important findings.
Okay, sir.
In the biopsy, I wanted your answer, Rajiv sir. Probably he should have mentioned about the differentiation.
Yes.
Whether it is a well differentiated or undifferentiated cancer really matters for your further treatment.
Grading of the tumor is very important.
Yeah, you did not mention in the biopsy. It is how do you find out in a squamous cell carcinoma? How do the pathologist find out whether it is differentiated or undifferentiated? On what grounds?
Basing on the number of mitogens per high power field, sir.
More important, more specific. Squamous cell carcinoma has got some specific pathological finding. Picture. Some pearls. Okay. Okay, tell me the risk factors for nodal. What are the risk factors for nodal metastasis to the neck? What were the risk factors?
Risk factor for nodal metastasis, sir.
Tumor size?
Yes, sir. If the tongue is involved, sir, then there is more nodal, bilateral nodal involvement.
Not really. No risk for nodal metastasis is not according to the site of the tumor, at least. It is tumor size, tumor grade, depth of invasion,
Okay,
perineural invasion, vascular invasion, all these.
Extraneural.
Okay. So you'll do what? You'll do an MRM for this patient. I'm sorry, radical neck dissection. I'm sorry, the radical neck dissection.
No, modified radical neck dissection.
What do you mean by modified radical neck dissection?
Sir, modified radical neck dissection is when we save all the three or any of the three of these structures, the spinal accessory nerve.
Okay. What are the types then?
MRND one is when you save only one structure, that is spinal accessory nerve. When you save two structures, spinal accessory nerve.
Type 1 is?
when you save only one structure, sir, spinal accessory nerve.
Okay.
Sir, type 2 is when you save two structures, sir, a spinal accessory nerve and the jugular vein, internal jugular vein.
Hang on.
And
Hang on. What do you mean by modified radical neck dissection? Which are the three structures? What is
spinal
radical neck
accessory
dissection
nerve
and what is modified radical neck? What is the difference between the two?
Sir, in radical neck dissection, we excise from level 1 to level 5 lymph nodes, along with the sternocleidomastoid muscle and the inferior jugular vein and the spinal accessory nerve.
Internal jugular, not inferior, internal
Yes, sir.
jugular.
Internal jugular vein and the spinal accessory nerves.
And submandibular gland.
And submandibular gland. And in
what
modified
modification
radical
here?
neck dissection, in modification, sir, we remove all the 1 to 5 level of lymph nodes, but we preserve any out of these three structures, sir. According to structure, we preserve. It is divided into 1, 2, and 3. So one.
Devashish. Radical neck dissection, you've got 5 structures, right?
Yes, sir.
You have the three.
Yes,
you have the muscle. You have the vein. You have the nerve, and you have a gland.
Yes, sir.
Right. In modified radical, you have to save the spinal accessory and the submandibular gland, and the you have to save the spinal accessory nerve. So you remove the sternocleidomastoid muscle, the internal jugular vein, and the submandibular gland. Isn't it? In type 1. No.
Yes, sir. No, sir. This submandibular gland is also saved, sir.
Yes, submandibular gland has to be saved in all. Has to be saved.
Yes, sir.
Has
all
to
the
be
modified radical neck dissection.
Submandibular gland has to be removed in all. 1, 2, and 3. Am I right, sir, Dr. Guru Shantappa?
Sir, what boy is highlighting, he is just mentioning what is preserved in 1, 2, 3. Yeah, he is right, sir. He is right. And submandibular gland is not taken into consideration when you classify these 1, 2, 3. Okay, we are interested in these accessory with jugular vein, jugular vein, and sternocleidomastoid 1, 2, 3. Okay, so for clarification, to make it simple. And what you said, the removed, yes, that is the one which are removed, level 1 to 5. With, you should mention lymph nodes and the lymphatic tissue with a fascia. With a fascia, okay, like in breast, because fascia will have lymphatics. So that is why when we remove sternocleidomastoid, why we should remove innocent sternocleidomastoid if the question is asked? Because sternocleidomastoid is covered by deep cervical fascia, which has got lymphatics.
Okay, sir.
Even IJV removal also is the same explanation, because IJV is innocent. It doesn't have any tumor inside the lumen. It has got a sheath there. It has got a sheath. Carotids cannot be removed. They are not sacrificable. That is why we don't touch that. IJV is sacrificable on one side. So because sheath has got lymphatics and lymph nodes are around the vein, so these are the structures removed. So importance is the sheath, lymphatics, lymph node tissue of all the nodes 1 to 5 with these 3 structures. Depending on which you are going to save, you are labeling 1, 2, 3. Okay, accessory, vein, muscle. Clear?
Yes, sir.
Okay, fine. Now, what is the reconstruction you will do? What is the local excision you will do for this man?
Sir, I do an wide local excision of this region with a segmental mandibulectomy.
How much area around from the tumor margin you will excise?
1 centimeter all around, sir.
Will you excise full thickness lip, lower lip?
Lower lips are...
full thickness you are going to excise, or you are going to... What will be the thickness of excision?
Sir, we have to excise the full thickness, sir. 1 centimeter will involve the full thickness.
Okay. What will be the reconstruction?
Sir, reconstruction, I would like to do an osteomyocutaneous reconstruction. If available, preferably a radial free forearm free flap, sir.
Okay, fine. It will include both soft tissue defect and a bony defect.
Bony defect.
See, whenever for postgraduates, because these questions will be asked in the MS examination, after any surgical procedure for oral malignancies, you will have 3 defects. One is a mucosal defect, second is a soft tissue defect, third will be the bony defect, depending on what surgery you have done. So to cover, we have three parts. Mucosal defect, either it can be covered with a primary surgery or a local flap. The soft tissue defect in the form of some flap, and bony defect in the form of osteomycutaneous flaps. Okay, these are the three defects you need to cover. And on the right side, what is the neck dissection? You will be doing MRND. Am I right? Okay. Yes, and you said you will be doing segmental mandibulectomy.
Yes, sir.
Okay. And a radial free flap osteomycutaneous.
Flap.
Okay. Fine. What are the indications for adjuvant treatment? Does he require any adjuvant treatment?
Sir, adjuvant radiotherapy can be given, sir, if there is more than 2 lymph nodes are involved, if there is perinodal extension are seen in the pathology, if there is perineural invasion of the adjacent structures are seen, and if there is perivascular invasion is there, so then it will require an adjacent radiotherapy, sir.
Yeah. Along with that, always know, as a student, when something is asked like this, take primary tumor first, then regional nodes. Primary tumor, what are the indications? If the margin is positive or very close, depth is positive for tumor, depth is, then undifferentiated or poorly differentiated malignancy is known for local recurrence. These 3 points from the primary. Then what all you have mentioned is for the secondary deposits, secondary lymph nodes. They become an indication for.
We close, sir. I think it's.
Yes, sir.
Right.
Okay.
Thank you, Debashish. Well done. Very well done. I think you've done very well.
Thank you,
sir. Thank you, faculty. Kanna sir, you'd like to give any closing comments, sir?
In any case of the oral cancer, if it is there, when you plan for the wide excision along with the, always you have to tell about the neck, that what you're going to do for the neck. And you rightly said that you will be carrying out the modified radical neck dissection, where you are going to save the spinal accessory, the internal jugular vein, and the sternocleidomastoid. So these are 3 structures. You know, you can remember by what are the various contents of a radical neck dissection? How many muscles you remove? How many nerves? How many vessels? Any idea about that? Which muscles are removed in the radical neck dissection? You know, you can roughly have an idea about 3. Everything 3 is there.
Yes.
So you are going to remove the 3 muscles. 3 muscles are the sternocleidomastoid, omohyoid, and probably the anterior belly of the digastric jaw.
Okay.
And there are 3 glands are there: submandibular gland, submental gland, and tail of the parotid jaw.
Okay, sir.
You remove the 3 nerves which are there. 3 nerves which are there is in the classical one, the spinal accessory nerve which is there, and then the C3, C4. Okay, so these are 3 nerves which are removed in that.
Okay.
Then there are 3 arteries which are there. 3 arteries is, sometimes you have to ligate the superior thyroid artery. Second is, just forgetting what is the name of, there are 3 arteries which are there. One is the transverse cervical artery probably, and Dr. Sai, you remember that?
Yeah, I think it's facial. Is it facial?
Is the facial, yeah, facial artery. Yeah, that's right. Yeah, facial artery.
Okay, sir.
So everything 3 is there, okay, in the classical neck dissection which is there. And then after this, you have to reconstruct that, and the reconstruction is done. You have to give a lining, you have to give a cover, and you have to give a support.
Okay.
So lining is the mucosal lining, cover is the skin, and support is the bone. So which you can do all the things at the same time, or at least you have to carry out the cover and the lining has to be done. And later on, you can postpone it for the support later on. Or you may use some type of the prosthesis for the support rather than any bone structure which is there for that. Okay, so these are the way you are going to reconstruct a case of the oral cavity malignancy. Thank you.
Excellently. No, very good. Excellently put.
Shanai sir.
So he has done a good presentation. Only one other, probably it has been touched, but I'm not sure. Subsets you should know, subsets. Today, oral cancer is not, everything is not similar guidelines in the oral cancer. You are asked sometimes, no, risk factor for the nodal disease. one of the important thing is the floor of the mouth, alveolar lesions. So comparatively, we have upper alveolus, lower alveolus, floor of the mouth, then of course buccal and tongue. So these are the subsets. So you also note, so that's also an area for the even a prophylactic neck dissection, even in the absence of the positive nodes. Especially you have got a poorly differentiated carcinoma and in the floor of the mouth. Large lesions like this, I think you also need to mention concurrent chemo radiotherapy. I think only radiotherapy was discussed. Cisplatin is the usually the drug which is also given in this type of situation. That's all, sir. He has done well. Good discussion.
Devashish, there are three veins which are there. Just forgetting that what I was forgetting. Three veins are the external jugular vein, internal jugular vein, and anterior jugular vein. So you can remember by all those three structures which are there.
Thank you, sir. Thank you. Debashish, you would like to ask any doubts or clarification to the faculty here?
Yes, sir. Thank you.
Thank you, Debashish. Thank you to Jojo sir for permitting you to present to you here in this platform. And you did well, and we'd like you to request to stay back for the next case also. Now I'd like to call upon, I'll have the honor of welcoming Dr. Vimal Life, a vascular surgeon from St. Luke's Hospital, Kochi. As Srikumar sir could not join, he has requested his another colleague, vascular surgeon, Dr. Vimal sir. Hearty welcome to join this. And we apologize for pulling you at the last moment. And thanks to Srikumar sir for helping us to get you on. Thank you, sir. Thank you so much. So we have Dr. Chaudhary to start his presentation. Can we have the case for Debashish, you should unshare your screen, please. Yeah, thanks. Chaudhary, you can introduce yourself and start your presentation.
Yes. Good evening, sir. Myself, Dr. Jaideep Chaudhary, third year resident, NHL Medical College, SVP Hospital, Ahmedabad, Gujarat. Under the guidance of Dr. Rajan V. Patel, Professor and Head of Unit, NHL Medical College, SVP Hospital, Ahmedabad. Presenting a case on peripheral arterial occlusal disease. Yes. I am presenting a case of 42-year-old unmarried Hindu male patient, laborer by occupation from lower socioeconomic class, presented with the chief complaint of pain over the right leg since last 6 months. There is brackish discoloration of toes of right foot since last 2.5 months. There is ulcer over the right foot since last 1 month. History of presenting illness. On origin, duration, and progress, patient was relatively asymptomatic before 6 months. Then he develops pain over the right calf on walking, which was cramp-like, intermittent, non-radiating, And initially pain develops after walking of approximately 1 to 1.5 kilometers, and pain disappears when he continues to walk. On progression, the distance reduces to 100 to 200 meter to pain to appear. Gradually, patient has to take rest to get rid of the pain, and at present, patient has continuous aching pain over the foot, even at rest, which is relieved by hanging his leg by the side of the bed, and it interferes with the sleep of the patient. Before 2.5 months, patient noticed blackish discoloration over the toes of right foot, starting from the little toe and gradually spread over the sole of the foot. Patient develops ulcer over the right foot since last 1 month. There is no history of trauma, fever, or any history of cardiac problem. There is no history of blackouts or loss of consciousness. There is no history of abdominal pain, impotence, thigh pain, or any pain over the buttocks. There is no history of blood vision. There is no history of minor pain, swelling, or redness over the affected part. On past history, there is no history of diabetes or hypertension. There is no history of ischemic heart disease or cerebrovascular attack. There is no history of similar complaint in the past or any history of surgical intervention in the past. Family history, not significant. On personal history, patient is vegetarian with normal bowel and bladder habit. Sleep is disturbed due to pain since last 1 month. Patient is chronic bidi smoker since last 20 years, taking 1 judi per day. On summarizing the history, 42-year chronic bidi smoker male patient presented with chief complaint of pain over the right leg since last 1 month, blackish discoloration over the toes of the right foot since last 2.5 months, and complaint of ulcer over the right foot since last 1 month. Sir, should I go ahead? General examination?
Yeah, hold on, no, at history. What do you think on history-wise?
Sir, yes, sir, this is a case of peripheral arterial occlusive disease according to the history of the patient. Sir.
Okay. Do you think it is an acute disease or a chronic disease?
No, sir, sir, this is a chronic disease.
Chronic disease. Do you think on history, is it an embolic phenomena or a thrombotic phenomena?
Sir, it is a thrombotic phenomena according to his history.
Okay. Now I will come back. You said it is an arterial disease.
Yes.
I say it is a venous disease which has caused all this discoloration and pain. How do you disprove, or how do you say that it is arterial disease, not a venous disease? On history.
Sir, on history, patient giving the pain over the right leg, specifically over the calf, and which is intermittent and cramp-like. It is started after exercise or walking and relieved on taking rest, sir.
Okay. One, anything else, any other, like this, any other points to say that yes, it is arterial disease, not a venous disease. So this pain aggravates after walking, and pain he gets in the calf muscle.
Other than this is, sir, patient having a rest pain and typical ulcer over the plantar aspect. And
rest pain may be there in venous diseases also.
In case of, sir, venous disease, ulcer mainly present over the gaiter zone or dorsum of the foot.
Yeah, what I expected was he doesn't have swelling of the limb, which is predominant in venous disease. Okay?
Yes.
Okay, it is for discussion. Then why not it is a neurological pain if you take only pain into consideration?
Sir, in case of neurological pain, pain may start after taking first step sooner or later, and it may not relieved on taking rest, but may relieved by taking specific position.
Okay. Why do you think it is a thrombotic disease, not an embolic phenomena, if it is an arterial disease on history?
Sir, if it is an arterial disease, the history may be different. Like a patient have sudden pain over the whole of the limb, and then gradually with swollen limb and gradually pain localized to the area of the block. And
any other point? Yeah, you are right. One point to differentiate. Any other point to say that it is thrombotic?
Sir, may have
Embolic disease, usually it involves the periphery of the limbs. Thrombotic, usually that this patient, what he has, the pain in the calf region, proximal muscles, thrombotic, and a chronic entity. Okay. Yeah. Fine. Why do they get, what is that typical pain in the calf? What is the terminology you would like to label?
sir, claudication pain.
Okay. You people may be knowing now how it is graded, why they get the claudication. I think there is no need to discuss. Yeah. You know, or?
Yes.
Okay. Fine. You have asked so many, the other histories you have mentioned, no history of so many list of diseases you have mentioned. And one of them is the impotence. Anything related with he's getting pain in the limbs and having impotence?
Sir, if patient have a higher level block or at the aorta or bifurcation, patient may have a history of buttock claudication with thigh pain or impotence.
How will you find out whether patient has got a claudication in the buttocks on the history? How will you ask?
Sir, difficulty in walking or standing.
It is climbing staircase. Okay, especially during climbing staircase, whether he gets pain in the thigh and the buttocks. That is a history we should be asking. If that history is there, what is that syndrome called if it is associated with impotence?
Laric
syndrome. Okay, so if that history is there, then you have to go into the depth of that. Okay, fine. How do you know whether the aorta, abdominal aorta also is involved and he has got the angina in the abdomen? What will be the typical history?
Patients are typically give the history of abdominal pain after taking meal, approximately 2 to 4 hours after taking meals, cramp-like, and may give history of melena.
Okay. What does rest pain in an ischemic limb indicates?
Sir, it indicates the involvement of nerves, peripheral nerves.
What is a synonym, like how it is described?
Sir, it is aching type of pain.
Cry of a
dying
nerve. Cry of a dying nerve. Okay. Yeah, please. Sir, Khanna sir.
Why did you ask for the blurred vision?
Sir, patient gives a history. Patient has a history of history suggestive of peripheral arterial disease, in which it may be due to the atherosclerosis or Berger's disease. So to rule out during this present illness, patient may have a history of blackouts or this blurred vision or in the past.
What is the age of your patient?
42 years.
Okay. So how will you differentiate between whether are you dealing with a case of atherosclerosis or you are dealing with a case of a thromboangiitis obliterans?
Sir, age of the patient.
40 years age goes in favor of thromboangiitis, or it goes in favor of atherosclerosis. 40 years age is in favor of atherosclerosis, or it is in favor of the?
In favor of Berger's disease.
Okay. What are the other criteria of the Berger's?
Sir, it is seen in smokers before the age of 45. predominantly affecting the lower extremities. And there is absence of other risk factor for atherosclerosis other than the smoking. And there may be history of superficial thrombophlebitis or
Okay. And what type of the blood vessels are involved in the Burgess disease?
small to medium size of vessels.
So where will be the claudication in this patient?
Claudication in the calf.
In the foot or in the calf? Okay, but not in the thighs. Okay. Okay, go ahead with your examination now.
On general examination, patient is conscious, cooperative, and well oriented to time, place, and person. Patient is fairly built and nourished. Generalized body temperature is normal. Pulse is 84 per minute in right radial artery with normal force, volume, and tension without radiofemoral or radioradial delay. Blood pressure is 130 by 78 mmHg in right brachial artery and 128 by 82 mmHg in left brachial artery in supine position.
Jaideep, can you wait for a minute? Vimal sir, you'd like to ask some questions, sir? Sorry.
It's okay. I think he has started the examination point. Just two comments before he proceeds on to the examination. One is he has not mentioned anything about the contralateral limb specifically in history. Do you think that it's significant? Or probably I will once he concludes the examination, I will chip in. And one more thing, nothing was mentioned about the treatment history on the patient, whether he took some treatment before reaching you. Okay, you can continue. We'll interrupt later.
Jaideep, this treatment part you want to answer now, or you want to finish and then take the question now?
No, patient haven't taken any treatment for this.
Okay, fine.
There is no history of pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Back and spine is normal. On inspection, right lower limb, there is a loss of hair over the right foot and leg compared to the opposite limb with transverse ridges present over the nail and skin appears thin and shiny. Muscle wasting is evident over the right side compared to the left side. There is guttering of vein on elevation of the right lower limb. Venous refilling time was elevated. It was 10 seconds. On Burgess postural test, pallor is not appreciated, but patient develops pain on elevation of the limb. There was no skip lesion. There's blackish discoloration noted over the plantar and dorsal aspect of all the toes and sole of the foot with edema present over the dorsum of the foot. There is approximately 3 by 2 centimeter size oval ulcer present over the base of the second toe on the plantar aspect with punched out edges with slough present over it and without any discharge from the ulcer. There is also a 2 by 2 centimeter size single oval ulcer present over the lateral border on the plantar aspect with eschar formation over the floor. Movement over the ankle, metatarsopharyngeal and interpharyngeal joint were normal. Left lower limb was normal on examination. So this is picture of bilateral lower limb. On palpation, right lower limb, all inspective findings were confirmed on palpation. Skin over the affected limb is cold below the knee joint than the opposite limb with hyperesthesia over the sole and the dorsum of the foot. Pitting edema present over the dorsum of right foot. Venous revealing time delayed as compared to the normal limb. There is 3 by 2 centimeter size single oval ulcer with punched out edges with slough present over the floor without any discharge from the ulcer base at the second toe and plantar aspect. There is also oval shape ulcer of 2 by 2 centimeter size with eschar formation over the lateral aspect of the foot. Abdominal aorta was palpable above the umbilicus. Inguinal lymph nodes are not palpable. So this is picture of on arterial examination. Bilateral dorsalis pedis artery pulsation were absent. and popliteal posterior tibial and anterior tibial artery were not palpable on right side. Bilateral femoral pulsation were present, and upper limb pulsation were present on bilateral side. On auscultation, there is no bruit heard over the bilateral femoral artery or aorta. On systemic examination, respiratory bilateral artery present. As on cardiovascular examination, S1, S2 was present. Per abdomen was soft, non-tender, and patient was conscious and oriented. Some provisional diagnosis. Case of right lower limb arterial occlusive disease, the probable site being the femoral-popliteal segment with pregangrenous changes over the right foot, probably due to Burgess disease, and the differential diagnosis would be atherosclerosis.
Yeah, Jaideep, can you have those just clinical photographs? Okay, in your examination, all the toes are discolored. Am I right?
Yes.
With a swollen foot.
Yes.
What about the hair loss? Has he got in the leg compared to the opposite side?
Yes, sir. There is a hair loss over the dorsum of foot and the ankle compared to the opposite side, and there is evident wasting over the right side.
Yeah. Did you measure the circumference of the leg on the right side?
Sir, no, sir. I didn't mention in the history.
Okay, because on inspection it is obvious. That's why you did not measure, or?
Yes, sir.
Okay. If you have been asked to measure, where will you measure the circumference to know the?
At mid calf level, sir, being from tibial tuberosity.
What does it indicate? What does it indicate?
At the same level, sir, on the.
No. What does it indicate ultimately if there is the wasting? What does it indicate?
Muscle ischemia, sir.
It indicates chronic ischemia. That's why they go for atrophy, chronic ischemia. Okay. And when you are presenting a case of ischemic limb, when you start inspection, did you mention the attitude of the patient, the posture or attitude, how the patient is sitting up, or how? Can you diagnose ischemic limb from a distance?
In arterial occlusive disease patient, sitting with hip and knee flex and holding his foot in the arm.
Okay. How does his eyes will be looking like? Will they have a night sleep, sound sleep?
No, sir. Patient had disturbed sleep, or he may sleep in the chair at night.
So they will have a glossy eye. Or he will be like in Kannada we call it as tugudsadu, like he will be snoring and suddenly he will be like that is from a distance. These are few points, may not be very important, but yeah, from a distance you can just look at and see that it is a ischemic limb. You said in the examination only right side femoral is felt and down there are no pulsations felt. Okay.
Yes, sir.
So is that sufficient, just mentioning that the femoral is felt on the affected limb, or do you want to mention few more points pertaining to femoral artery? Because it is felt.
Sir, if compared to opposite limb, if it is feeble or not, that is required to mention. And
volume, is it the same volume as opposite? Okay, that you should mention.
Even the palpation of both arteries, even the similarities also you have to mention, and whether they are normal as per your experience, that is important to rule out atherosclerosis clinically, right? There can be some firmness or diminished pulsation bilaterally. In
Sir,
case
I would like to add that same point here, that femoral artery, pulsations, volume, and also bruit or a thrill, that also should come here. And in the general examination, you mentioned about brachial artery. If it is very prominent, you need to mention locomotor brachialis thickening, because that gives it, tilts your diagnosis to atherosclerosis. So you understand, no? So that is what
Yes,
these are
conditions of the vessels,
few
overall
points
conditions of the vessels.
in a vascular case. This has to be recorded. And just one more point, that looking at the lesion, you said pre-gangrene, but foot is showing all that gangrenous patches only, which have been debrided, I think. Can you show that foot? Yeah, what is that patch? Do you call this as that big ulcer-like thing is there? No, what is that? What is that? Yeah. No, what I'm trying to tell is how that happened. How that big ulcer.
How did the ulcer develop? Spontaneous, or it has been debrided?
No, sir, spontaneously developed.
Imagine how it can happen spontaneously. Can you trace the events?
Sir, patient may have a minor trauma or
One, yes, trauma, infection, cellulitis, or added by vascularity. Can you see one more ulcer on the lateral aspect there? Can you see that? I can make out a. Can you see that? Yeah. And so at this juncture, one other question they may ask you: is it diabetic?
Diabetic, yes, neuropathy.
So you need to add that in your diagnosis. You understand? No. If you look at this lesion, also there is some element of diabetes, because if it's purely TAO and all that thing, you won't get like this.
Yes.
You won't get. It will be confined to the tip of the toes like that. So
even toes are little swollen. They are not shriveled or decreasing in volume.
Yeah, these are some of the observations. Yes.
This is where, as Dr. Vimal sir pointed you about history of other limb, you should also begin your examination from the normal limb, and then you compare it with the affected limb. Somewhere you mentioned pitting edema. What was that slide? Did you mention that it is not there, or it is there?
it is there, sir.
So how can you explain pitting edema in an ischemic limb?
Sir, it may be the process of developing a line of demarcation from the zone of demarcation.
Pitting edema, where did you find?
Sir, on the dorsum of the right foot.
Is it pitting edema or induration?
Sir, it was edema, and a patient has, with hyperesthesia over the dorsum of the foot. So it may be, sir, the development of line of demarcation from the
pitting
zone
edema,
of
pitting edema will be there. See, everywhere we mentioned that there is atrophy in all, because the blood supply is reduced. This is the two main difference between arterial and venous disease, where in one case where the blood supply is diminished, that's why it gets smaller in size, and in venous disease it gets edematous, engorged, because the venous reduction is reduced. This is the basic difference. What about the shapes of toes of other limb as well? Are they normal? Why do you see the prominence of extensor group of muscles?
Sir, the nutritional status of the patient.
Vimal sir, your questions, please.
Yeah, Dr. Jayati, a few queries. Before labeling, your provisional diagnosis after your history and clinical examination is Berger's disease or thromboangiitis obliterans. What are the characteristic features in history that you exclude before you stamp the patient as a probable TAO, or what are the criteria you say that the patient is very likely candidate by history that the patient would be more fitting in for TAO?
Sir, the age of the patient.
What is the general cutoff age being told us?
20
criteria for
20,
up to what age you consider?
Sir, for after 20 years, 20 to 40 years of age.
Yeah, 45 is generally the cutoff. Okay, then
They, sir, the smoking is an important risk factor for TAO, and
oh,
there is
okay.
no other risk factor that uh, that support the diagnosis of atherosclerosis.
Okay.
Georges.
What are the risk factors you would like to rule out in history?
Sir, hypertension, diabetes, dyslipidemia.
Okay. So presence of diabetes and other risk factors like a hypercoagulable state and an autoimmune state. This hypercoagulable state and autoimmune state very unlikely will get in a history. It's a biochemical evaluation. So all these three are criteria to put the patient into TAO. What is classical in this patient? Can the patient have a can this still be an atherosclerotic or an accelerated atherosclerotic phenomenon in this patient? Would you still consider? Yes or no, or likely or unlikely?
No, sir.
Yeah, good. Regarding you mentioned about inguinal nodes, probably. Would you say that would you reconsider examining the patient, telling that the patient has got a ulcer for a long duration and pedal edema, probably a sign of infection or ascending infection? Are you very sure that the inguinal nodes are absent? I would suggest that you re-examine the patient, and then very likely patient has got groin nodes. It's a sign of ascending infection or active infection. What would actually hyperesthesia in the foot mean, or what would be it suggesting to in a patient with advanced occlusive arterial disease other than diabetes?
Sir, it suggests the vascular insufficiency to the peripheral nerves, somatic nerves.
It's a cutaneous circulation which is taken off into the deeper muscles, especially when the patient is in an ambulant stage, which leads to hyperesthesias. Okay, doctor, you carry on.
I'd just like to ask you a few questions. You said that the patient's attitude would be he would be sitting with his knees flexed and holding his foot in his arm in his palm. Why do you think he would be doing that?
Sir, he tries to warm his limb.
Right. So he uses his hands to warm his limbs. Right. Okay. You said that your differential diagnosis is atherosclerosis. Can you clinically, on your examination, find out whether the patient is having atherosclerosis?
Yeah. Sir, patient may have signs of atherosclerosis like xanthelasma or.
Right. So you've not mentioned them. You have to mention them. You've not mentioned any of those features to rule out atherosclerosis in your examination. One is xanthelasma. What else?
Locomotor brachialis.
So xanthelasma, there'll be arcus senalis. There'll be this thing, a white this thing around the pupils. There'll be premature graying and balding. These are all signs. Nicotine stains, central obesity. These are all signs, right? You'll have to look for them, right? Also, you've not told me anything about the gait of the patient. Have you checked his gait? You've not checked his gait, right? I tell you that this is a diabetic foot. It could be a diabetic foot. You don't know whether he's diabetic or not. Clinically, up till now, we don't know. We've not done any investigation.
Sir,
so how can you rule out?
Sir, a diabetic patient have peripheral neuropathy. Patient don't have pain, may walk with normal limp or in.
No, there can be pain. It's not that all diabetic foot patients don't have pain. There can be pain. No, why do you think this is an arterial disease? The ulcers, where do you think the ulcers would be in a chronic arterial condition?
Sir, the ulcer have punched out edges with deeper extension to
Look,
muscle.
arterial diseases can present with pre-gangrene or gangrene, or can present with ulcers, right? Usually in arterial disease, we don't get arterial ulcers very easily, except when in long run there's trauma and doesn't heal. You'll have shriveling of the foot, you'll have change in color of the foot, all that, isn't it? So you have to mention all that. You have not mentioned in your examination. What about sensation? What about sense of vibration, positional sense of the joints? All that has to be tested.
The patient has hyperesthesia.
Okay.
See, Chaudhary, you are all the time telling hyperesthesia. It should be your policy. Whenever a leg problem, even in a varicose vein patient, you need to check for dorsalis pedis. Very often you may mistreat that. If patient is having pain and you see varicose vein, like what you are seeing, one prominent vein in the other leg there, and you may operate on varicose vein, and he may be having arterial disease. So you need to check for sensation, pulsations, and again, with the diabetes, vibration sense, one of the early thing to get lost, no? Vibration sense.
So you have to do all those tests.
Then gait, whatever it is, gait, lymph nodes, they've been already mentioned to you. And as a matter of principle, completion sake, you need to also specifically mention is got a carotid bruit, because these are the patients may develop a stroke. If there's atherosclerotic patients, we can warn them. So at
in
least
fact, the most common cause of death in these patients is MI or stroke.
So all the details of it's a generalized disease. So whenever arterial disease is given to you, you need to examine for all the vessels and particularly give more details. And a basic rule, whenever a pulsation is of any vessel is prominently felt without much effort, you need to think of a aneurysmal dilatation. Is it clear? If you feel, let us say, subclavian is easily palpable, okay, or carotid is easily palpable, or with some, so always suspect an aneurysm. That's all from my side. Yes.
Okay, Jaydeep, you said there are ulcers. Sorry, you said there are ulcers. So what are the type of ulcers which you'll find in the foot, and how can you distinguish between them?
Sir, arterial ulcer, venous ulcer, trophic ulcer.
Okay. So what is the characteristic between how will you differentiate between the three ulcers?
Sir, venous ulcer most commonly seen over the gaiter joint, over the medial.
Okay, the side. What about arterial ulcers?
Arterial ulcers are seen mostly over the toes or the head of the metatarsal, and the trophic ulcers are seen over the heels or the malleoli.
Okay. So why do you think venous ulcers are seen in the gaiter area?
Sir, the venous pressure column is highest.
Why is it highest there?
Highest at the.
What do you mean by gaiters area? Which is the gaiters area?
Sir, it is the area above the medial malleolus.
Okay. So why are these ulcers? Why not on the lateral malleolus? Why is it not on the medial malleolus? Because the great saphenous vein is on the medial side. So all the column of blood, when the valves are gone, the pressure is maximum at the medial malleolus. If at the lateral malleolus, you think of an arterial. On the medial malleolus, you think of the venous, right? And why are there neurogenic ulcers at the heel and not elsewhere, or metatarsal side or pressure points? Because in these areas, the skin is in direct contact with the bone. There's loss of sensation, so there's chances of injury.
Sort of pressure sore.
pressure source, right? So there's only the skin and the bone in between. There's no muscle in there. So you get this, right? Okay.
What is
So
the normal venous pressure at the level of the ankle in the standing posture? How much is the venous pressure? Okay, it's around 80 to 100 millimeter mercury. Okay, so do not think that the venous pressure here will be like 2 or 3 millimeter mercury. It is almost about 80 to 100 millimeter mercury. Okay.
And can go to 200 while walking. While walking, it can go to 200, 250.
And what is the ambulatory venous pressure? How much is that?
Sir, it is
ambulatory venous pressure is the pressure when the patient walks. Okay, at that time, this pressure falls down. It can come down to about 20 to 30 millimeter mercury.
two-thirds.
For the development of venous ulcer, this ambulatory venous pressure is very important. And it has been shown that in the venous ulcers, this ambulatory venous pressure, the normal venous pressure may be the same, but the ambulatory venous pressure may go up to 70 or 80 millimeter mercury. So higher the ambulatory venous pressure, more is the chance of having the venous ulcer. Okay. Now in the pulse examination, you said that the force, volume, and tension. I was just looking into that. What is this force and what is this volume and what is the tension? You mentioned 3 words there.
Yes, sir.
You
Force.
did not tell about that. What was the rhythm of that pulse? That was the most important thing. Apart from the rate, you did not tell anything about the rhythm.
Sir, force being measured with the index finger while palpating the vessel. The force need to obstruct the flow, gives the idea of systolic pressure, and the tension, the volume measured with the middle finger, the uplifting of the middle finger gives you the idea of the volume of the vessel.
So can you really differentiate between all this force, volume, and tension? You just tell whether it is a normal volumic pulse or whether it is a bounding pulse is there or it's a low volume pulse is there. That is the only thing which is mentioned. How do you take the temperature of the limb here?
Sir,
measure the temperature?
Sir, with the back of the hand, comparing to the opposite limb, sir, it was cold.
What was happening in this limb?
Sir, the temperature below the knee on the affected side is colder than the opposite limbs.
What does that indicate?
Sir, that indicates the chronic ischemia, sir.
No, that will tell you that how much is the development of the collaterals which is there. Okay. So if there's a collateral supply is good, then the temperature will be maintained. If the collateral supply is poor, then the temperature will not be maintained. And if you have to decide about specifically for the amputation for these patients, then you have to keep this thing in mind. Apart from carrying out all those Doppler studies which are there, but the temperature has also to be kept in mind for deciding about the level of the amputation.
Yes.
Okay, so keeping this patient as a case of a Burz's disease, how you are going to investigate?
Sir, to start with the routine blood investigation. And
what is the routine blood investigation here?
Complete blood count and renal function to start with, and with duplex scan.
So what is the first investigation you're going to carry out? Is the routine investigation going to give you any clue about that diabetes?
Anything specific in routine? Dr. Ajay was asking you probably anything specific in routine blood investigations you are looking for?
Lipid profile and
okay, blood sugar is very important. Okay, that is probably most important thing. Can you listen me?
Yes, sir.
Blood sugar is probably the most important thing in your routine examination.
Yes.
Okay, whether the patient is diabetic or not. Okay, then you have to get the lipid profile there.
Yes.
So what the duplex is going to show you here?
Sir, duplex scan shows the blood in the flow in the vessel, the site of occlusion, the status of the proximal and the distal vessel.
What do
Will
you
not show the
understand?
status of proximal distal, sir.
What do you understand by duplex scan?
Sir, it is beam mode ultrasound combined with the Doppler, in which beam mode ultrasound isolate the image and Doppler
Demonstrates flow.
What exactly would you get in, or are you looking for in a B mode ultrasound?
Sir,
You only isolate the vessel, or you do look for something else? What is the color of the image like in B mode? Is there any color at all?
Yes, sir. It gives color, the flow of the blood and the direction of the flow.
No, we are talking about B mode ultrasound. So that is a grayscale imaging. So you look at basically the wall thickening and calcification, that you can pick up calcification, and also presence of thrombus, especially in venous disease. Arterial disease also you can pick up thrombus by B mode ultrasound. It's not, color is different. Color comes in Doppler ultrasound. Okay. So what do you look for in Doppler?
Sir, the site of occlusion or the length of occlusion, the flow, the velocity of the flow.
Mm-hmm. Can you elaborate what exactly, for postgraduate purposes, what exactly
I'll just give you a brief on it. Yep. B mode is anatomy. So it will tell you the anatomy, the course, and any variation of the vessel. It will tell you the wall contour, whether there is aneurysm or stenosis. It will tell you the wall structures, whether there's calcification, plaque, or cysts. It will tell you if pulsation, and tell you of the perivascular structures, if there's a hematoma or an abscess or anything. The Doppler will demonstrate flow. The flow is direction of flow, the pattern of flow, whether it's lamellar or turbulent. It will tell you about profile, whether it's monophasic or biphasic, triphasic, and the flow velocity. So these are the structures which you see, things which you see in duplex scan. Right?
Actually, B stands for brightness, right? Depending upon the, in black and white screen, depending upon the dark and otherwise status, you differentiate the structures.
Or in other words, B for anatomy of the vascular structure, Doppler for physiology of the vascular structure.
Yes, sir.
Crossly.
Very, very well said.
Yeah, if this is the case, any other investigation in the human being where this fits into? One investigation for anatomy, one investigation for physiology. Out of this case.
Something to do with kidneys? Yeah, go on. You know it? Right, go on.
DTPA scan and
right. And? DTPA and? DM?
DMSS scan.
Right. So you have that. Okay. Have you done the ABPI?
No, sir. The OPD based patient, and I haven't.
Okay. Okay. Oh, please, sir.
How do you do an ABPI? How do you define ABPI?
Sir, ABPI is the ratio of ankle pressure divided by the highest brachial pressure in the upper leg.
Highest of the brachial pressures, right to left. Okay. What's the normal value?
Normal value is, sir, between 0.9 to 1.3, 1.2 or 1.3.
So if it is 1.2, can it be always normal?
No, sir. It could be due to the calcified vessel or.
In which group of patients it can be falsely high?
Diabetic patients.
Okay. And in such patients, what else would you rely on? If your ankle brachial pressure in a diabetic is 1.2 and you don't get a palpable pulses in the pedal arteries or the crural arteries, what else would you add on to the ankle brachial measurement? Heard something, measurement, something distally in the foot?
Transcutaneous oximetry.
That's one step ahead. Do you have a transcutaneous sensor in your hospital? Have you seen one? It's quite inexpensive. We'll come to that later. It's called the toe pressure measurement. So toe pressures are more indicative of or more representative of a vascular occlusion in a diabetic because the pedal arteries are rather spared of calcification. So in a proximal vessel, you can have vessel calcification impeding the BP cuff, occluding the pressures. That's toe pressure with an infrared sensor is more representative. So any idea what is the toe pressure range like?
40 to 70.
Usually it's somewhere below the range of 40. It's considered significant.
Below 30 is considered, sir.
Okay, critical. Okay, doctor.
Right. So suppose you don't have a Doppler machine, you can use a pulse oximeter and a BP instrument. You can inflate the cuff and see where when the pulse oximeter says 0, you can know the pressure. Right. That's the one way. Also another way of doing this, known as Lancaster method. Right. Go on, sir, please.
Yeah. How do you proceed with this case now?
What is your Doppler result like? You have the Doppler result with you?
No, sir.
No, you don't have. Okay. So how do you proceed as Dr. Jay asked, how do you proceed with this patient?
I think, sir, Vimal sir will give a scenario. Like,
yeah, fine.
Just give him one scenario of a Doppler report and let him come out with a management.
Patient has got a normal vasculature in the proximal iliac and the common femoral and the superficial femoral artery. The distal superficial femoral artery wall shows thickening. The popliteal artery shows occlusion and collaterals proximal to the first part of popliteal artery. The distal popliteal artery or the infrageniculate popliteal artery is reformed through collaterals. And there is diffuse wall thickening of the tibial arteries with monophasic flow only detected in all tibial arteries. There is hardly any flow detected below the ankle joint level. So this is your Doppler picture.
Chaudhary, you understood?
Yeah.
Any clarifications you want?
You understood the sir's details of the Doppler report?
There is an occlusion at the popliteal, SFA popliteal junction.
This is acute phenomena, thrombi maybe.
See, sir has told you collaterals at the level of popliteal. So how can there be collaterals in acute phenomenon?
Sir,
yeah, to make it simple for you, what sir is mentioning, there is a occlusion proximal to popliteal and there are collaterals, and distal to ankle, there are no flow.
Sir,
first thing, if this is the report, are you happy to treat this patient?
No.
Why no? Ultimately, why you are not happy to treat this patient with this report? Why? Why you are not happy?
Sir, the distally flow is.
In other words, what is the aim of treating any ischemic limb? If any treating clinician, if he is not going to or not able to achieve that aim, then only we will not be happy to treat any patients. That is overall, any patient, including pregnancy.
I think Jaydeep is confused. Did you expect another Doppler report, or do you want to go further and then decide upon the treatment of this patient before you say yes or no, I can treat this patient?
Sir, I would like to go for CT angio to decide the treatment of.
Look, Jaydeep, we have got a panel of of doctors help you out. So if you don't understand, you just ask. You say, sir, I don't understand. Tell me what should be done. Okay.
Yeah, just tell us what is that CT angio is going to tell all of us than what Doppler has told us already.
Sir, it would give you the idea of level of occlusion, the length, and the collaterals, and it would give you the flow, distal runoff and proximal running.
Okay. One you left, one you said site, second you said length. Then what about it? Is a tube we are talking about. It is a tube.
Wall condition, the calcification or...
So whether it is a complete occlusion or not. Length you said, site you said, then whole of it, whether it is occluded. Then the distal. Okay, it is going to inform us.
Just adding on what Dr. Alakachin has told, basically you have to identify whether it is a stenosis. Stenosis means something less than total occlusion, and quantify the stenosis. That's a percentage of stenosis. Okay. Second is, if it is an occlusion, how long is occlusion and the site of the occlusion. The third thing is look at is the inflow. Inflow, you told, the correct word for it is inflow, where before the occlusion of the stenosis, how is the vessel? Is there any disease? How is the wall? Then comes what is known as the outflow. After the occlusion, how is the vessel flowing down? Is there any narrowing? Is there any vessel wall disease? All these are important because if you are planning a revascularization, you are sure that you don't have a disease upstream and you have got a landing zone good enough for your procedure down also for the vessel to remain patent. So these are the information you get from a CT. Apart from CT, any other modalities of angiogram you have heard of?
MR angio, CO2 angio.
Yeah, MR angiogram and a catheter angiogram. So which is a gold standard and what are the advantages and disadvantages of each? If you can tell one or two with respect to each. Where do you prefer a CT? Where do you prefer an MR? Where do you prefer a catheter angiogram?
Sir, MR angio preferred in case of altered renal function or in case of altered renal function.
Suppose the creatinine of the patient is 1.7, not on dialysis, diabetic. Would you do an MR angio?
No, sir. I would go with the CT angio with hydration of the patient.
And if the creatinine is around 2.2,
then also, sir, CT angio could be.
And why did you say MR angio is preferred in renal dysfunction patients?
Sir, in chronic renal failure or in chronic renal failure, we would like to go for the MR angio.
See, basically, you have to understand that what exactly are the contraindications for doing an angiogram. A patient who is on one end of the spectrum where the kidneys are already gone and is on dialysis, irrespective of what you do, MR angiogram, CT angiogram or catheter angiogram, the contrast is not going to do any harm or any good. If the patient is on the other end, whether the patient has got a normal renal function, you just need to take precautions prior to doing an angiogram, do a creatinine, hydrate the patient and do the angiogram. The third group of patients is patients on a renal dysfunction. That is borderline, you have creatinine clearance borderline. So the creatinine is something like 1.5, 1.7 to 2.5. These patients are prone for what is known as a contrast nephropathy and they can be pushed into dialysis. In this group of patients, a CT angiogram is absolutely contraindicated. An MR angiogram is also absolutely contraindicated because what is the dye that you use in MR angiogram?
Gadolinium.
Yeah. Can gadolinium cause any insult to patients with renal dysfunction?
Nephrogenic fibrosis.
So these patients with, how is nephrogenic systemic fibrosis manifesting? How do they manifest and when do they manifest?
Nodules over the joints or eyes.
It is more of a cutaneous manifestation. And when do they manifest? Like in a contrast nephropathy, is it immediately precipitated? And how fatal it is? It is something which manifests over years. presents over years, and the patient's disease condition is fatal. They progressively go into all sort of complications, systemic as well as cutaneous and subcutaneous fibrosis. So both in a renal patients, FNA patients, the only option you have is a Doppler supplemented by what is known as a plain MR angiogram. So you can visualize vessels because MRI has a principle of detecting protons. So wherever there is fluid, it picks up what is known as plain MR. Without contrast, you can delineate the vessel, but it is not as good as a contrast MR angiogram. Now you have another option of doing an angiogram in the patient, doing a catheter angiogram with the intention of treating them also. We'll come to that later. Okay, so this patient has had a normal renal function. The ABI is probably 0.3, and your CT angio shows a confirmation of the Doppler findings with a popliteal artery more than 90% stenosis, close to 100%, with a lot of collaterals from the distal SFA, reformation at the tibial artery level. What are the classical appearance of collaterals in a Burgess disease?
Corkscrew appearance,
Corkscrew collateral. So that indicates what? The collaterals indicates what?
The collaterals indicates chronic.
Yeah, exactly. It's a chronicity of the disease which is indicated. So it is better delineated in a digital subtraction angiogram, which is a dynamic study. Okay. So any other questions, please?
You can carry out the CO2 angiography. If the
we are coming to that, sir. So carbon dioxide angiogram is probably something which can be useful in the cath lab, where you do instead of a contrast, you give carbon dioxide in a controlled pressure manner, and you get a negative contrast. The visualization is not as good as a contrast angiogram, but always you have a safety on the kidneys. So CO2 angiogram is another option in renal dysfunction patients, just for your knowledge. Thank you, Dr. Ajay, for adding that. So patient has got this clinical picture. Patient has got severe rest pain, disabling his sleep. Is a threatened limb. Do you want to classify? What are the classification available for critical limb ischemia patients? Any idea?
Void classification. There is Fontaine and Rutherford classification.
So what is the current classification, and can you classify this patient according to the Rutherford-Becker classification?
According to Fontaine classification, it is stage 4 with ulceration, and with Rutherford classification, it is stage 5 minor tissue loss.
So you have the Rutherford-Becker classification is the current status, and it is almost going on to a irreversible damage phase. So what are the components of treatment you're looking at this patient? What exactly are you looking at in this patient with it's a critical limb ischemia? Can you define critical limb ischemia for benefit of your colleagues and postgraduates once?
Critical limb ischemia, it is the rest pain occurring more than of 2-week duration and requiring regular analgesia, ankle brachial pressure index less than 0.5, and there is maybe presence of ulceration or gangrene.
Probably you told all the things, but you mixed it up. See, it's a component of clinical findings plus objective evidence. So you should have rest pain not relieved by analgesics of more than 2 weeks duration. Also with or without tissue loss. That could be gangrene or ulcer. Evidence by an ankle systolic pressure less than 50 millimeters of mercury. So this subjective and objective evidence should be there on defining critical limb ischemia. So this patient has got a critical limb ischemia, Rutherford class 5 with severe rest pain. So what are the first things you address on this patient? Your diagnosis is thromboangiitis obliterans. Agree with that. What are the components you should address, and what is the aim of the treatment going to be?
Sir, as this, there is no clear line of demarcation present in this case, and patient having rest pain. Sir, I would go with the medical management and cessation of smoking as a general measure, and let the line of demarcation to develop and
Exactly. So you treat the infection first. Control of pain is a basic primary treatment in patients with critical. You give pain relief. You can see the next 48 hours patient will be sleeping. So what do you have you heard about WHO step ladder of pain? How do you control pain? What are the options in your armamentarium to control pain in ischemia? Do you think that you can control pain in this patient?
Sir,
Yeah, this WHO step ladder of pain, you starts with paracetamol, you step up with NSAIDs, then you have opiate analgesics, and you have other modes of treatment like interventional treatment. What are the interventional treatments available for pain management in ischemic rest pain?
sympathectomy, lumbar sympathectomy.
How does it help?
Sir, it with lumbar sympathectomy, there is it interfere with the
What do you destroy or what do you aim at doing a lumbar sympathectomy?
we destroy the L1 to L4 ganglia and destroy the nerve supply to the limb. And
you destroy the entire nerve supply to the limb.
No, sir, somatic.
Which ganglia are you aiming at?
L1 to L4, sir.
You got sympathetic ganglia, you got parasympathetic ganglia.
Sympathetic ganglia, sir. Sympathetic ganglia.
So what are you basically looking at? You're trying to avoid vasoconstriction so that there is a redistribution of flow to the postcapillary area. So the sphincter constriction is avoided. So lumbar sympathectomy we have got this. What are the modalities of modes of delivering a lumbar sympathectomy? How can you perform a lumbar sympathectomy?
Sir, chemical and surgical.
Okay.
By means of chemical, we use 5% phenol.
How do you deliver it? How do you visualize where to inject?
Under fluoroscopic guidance.
Okay, it can be fluoroscopic with a C-arm or a CT guided. Okay. So what do you inject basically? What material?
Phenol, 5% phenol.
Okay. What is the most severe complication or dreaded complication of a chemical lumbar sympathectomy? Which structure passes close to the transverse process of the lumbar vertebra? Sometimes it courses down from both sides of the vertebrae and unites at the middle at the pelvis. It's ureteric necrosis. You can have an inadvertent injection in the ureter and ureteric lysis can occur. So that is a procedure which is recommended to heal superficial shallow ulcers. It cannot cure the disease. Probably it can heal or alleviate pain in a superficial shallow ulcers. Any other area in the body where you do a sympathectomy?
It's a Horner's syndrome.
Which all ganglia?
Cervicodorsal sympathectomy.
Okay.
C8T1.
So this patient, you have suggested chemical lumbar sympathectomy on this patient. Any other options for this patient? How do you optimize? You got other modalities of pain blocking like nerve blocks, epidural infusions to get rid of your time where you revascularize a patient. So nerve blocks and epidural infusions and transcutaneous opiate patches are also in the armamentarium of a pain treatment problem. Now the aim of the patient is or treatment is to get rid of pain to limb salvage. So what are the modalities of limb salvage in a peripheral occlusive arterial disease generally?
Endovascular and surgical.
Okay. So what are the criteria which basically by task guidelines. What does task stand for?
Transatlantic Society classification.
So what does it basically depend? It has got A, B, C, and D. How do they differ? Each group differ. To be in broader concept.
Gives the idea of it divided, classified according to the length, this site, the involvement of trifurcation or not. And
so it's basically aortoiliac, femoropopliteal, and infrapopliteal. So longer the lesion, what is the treatment offer preferred?
Open bypass surgical.
Revascularization by task guidelines is task A and B, which are shorter, are preferred for angioplasty. C and D, which are longer lesions, you have a bypass option. But over time, C also is also included in angioplasty options. But what is the basic criteria apart from task? If you have a treatable lesion, which considered you to treatment arm, surgery or endovascular, how do you decide? In Indian scenario, if you got a short occlusion, 3 centimeter superficial femoral artery occlusion was a finding in this patient, a case of accelerated atherosclerosis. How do you decide whether the patient can be taken for angioplasty or for a bypass?
Correct. Life expectancy of the patient.
Okay, good.
And the comorbidity patient.
Exactly. So the most important factors are, one is the risk stratification of the patient. A good risk patient can be taken for a bypass. A high risk patient, even though the lesion is long, you might opt for a angioplasty in a longer lesions also. So life expectancy, as you told, whether patient is ambulant, is a patient bedridden, all these are factors making decision. In the Indian scenario, finances are also an important part in decision making. Okay, sir, any other comments from the house? Probably I was taking him along with me for a long time.
Sir, I think in the MS examination, what we insist about the lumbar sympathectomy, since in most of the ischemic limbs, this is the procedure which in the past every surgeon used to do. So not very much done, according to my knowledge. I don't know what others. Not very much done surgery, because you have other better options available nowadays. So probably if Jaideep, if things are asked, what is the best surgical procedure if it is opted for this person? Any procedure? Because now things are available in many places.
Sir, we go with the bypass.
Vascular bypass surgery. Okay. Do you think, can you save the limb for him?
Yes, sir.
In spite of doing bypass, can you save the limb?
Sir, the femorodistal bypass in this case have long-term outcome would be not as good as.
Yeah. See, this patient, what we expect, already there are set gangrenous changes in the toes. Already the gangrene has been set already. So even if you do a bypass, you are not going to save the whole limb. You can help him out preserving or most of the limb. That should be the aim, so that he will be able to walk, he will be able to manage himself rather than going for a amputation. So for this particular case, I hope this should be your way of, and it was a lot of discussion. Kanagavel sir.
Yes, sir.
Yes, sir.
Kanna sir, or any other points to be added, sir, before we call it as a close? Vimal sir.
Examination, I just wanted to add 2 things. You just mentioned radial relay and radiofemoral delay. What exactly would you look for in that? What are you intending to look when you have a radial and a radiofemoral delay? Before we conclude.
If there is a lesion at aorta coarctation or
so you're looking only for a radial and radiofemoral. Can coarctation lead to a radial delay?
Sir, abdominal aorta coarctation leads to radiofemoral delay.
Okay. So why do you look for a radial delay?
Radio retail for sir.
The patient has got generalized atherosclerosis. Pardon, you told something? I didn't get you.
Subclavian stenosis or
Exactly. So that's why Dr. Rajagopal Shanai, Professor Rajagopal Shanai was insisting on that candidates should not just see gangrene and stamp them as a peripheral occlusive disease limited to one part of the limb. You should always look for carotid bruit, and the completion comes with examination of subclavian bruit also. Probably you missed those 2 points. So if you have a unilateral subclavian stenosis or an occlusion, you can have a radial blade. How would you confirm that? You do a blood pressure test on both arms, which are not done by regularly. I don't think in my MS life also I have never examined BP in both upper limbs of our patients. We just take it for granted that we have examined. So as a postgraduate, you would always look for the complete vascular system, never ignore vascular cases, thinking that ulcer alone is a crutch. You might have a iliac bruit on the flanks. He might also have a carotid bruit and things like that. So be very particular. And also in the peripheries and extremities, you get an extremity case, lower limb case, whether it be arterial, venous, malformations, tumors, lympho-neurovascular. You have to examine the lymphatic system, the proximal nodes, neurological assessment, which was incomplete as other surgeons told, proper sensory and motor examination, especially in a patient, and the gait was missed in this patient. That is very important. If the patient is able to walk, he should gait, antalgic gait or what sort of gait, and arterial system. Why is this thromboangiitis called as angiitis? It's actually the arteries we are looking at, no?
Sir, it involves the artery as well as vein also.
So what is a characteristic histopathological picture when you look at the arteries? Any idea?
Sir, thrombosis, which on histological examination having microabscess composed of neutrophils and surrounded by granulomatous inflammation.
So we got thrombus in the arterial within the artery, as well as, is it an immunological phenomenon or non-immune phenomenon? Any biochemical markers you have to assess the severity of the disease. If it is not an infected case, you got ESR and CRP. There's a criteria which, so ESR and CRP also adds to the benefit. And you should, for a completion, you should also when you have a Burgess disease, very rarely in these days you get Burgess disease. You should also tell the pack years. The cigarette smoking as pack years, 20 into number of years is significant in the history. Then also in Burgess disease, you have got this patient, probably you may not be able to save the limb. In a non-revascularizable limb, that is after an angiogram, and in a case where you cannot salvage the heel of the limb, you have got certain options for salvaging the limb. That's called, have you heard of prostaglandins?
Yes, sir.
So where you cannot do a bypass or an angioplasty, you can give prostaglandin infusions, but that's not a sure shot. It improves vasodilatation. It has got an antiplatelet action, and probably in a shallow ulcer patient with distal ischemia, it can give. There are also studies showing stem cell therapy, intramuscular and intraarterial, can do good, but it's all theoretical, not an accepted norms, except for few centers which have brought few studies. Okay, good, Jaydeep. For an MSX student, probably, I think you probably had missed a few important points in the history. Otherwise, discussion, it was quite good. Anything more, Kanakavil, sir?
Sir, I think the standard has gone beyond MS levels in the discussion. I think Jaydeep also has prepared very well.
Very well.
He is able to take more tougher questions with ease, and probably this was mere oversight or something. He missed a couple of things. That's okay. Hitesha, you want to add something?
I think, sir, as a completion of cervical rib or scalenotomy, I mean scalenocenticus syndrome, we do cervical sympathectomy. So that will give better results, isn't it?
Yeah, okay, exactly.
And it is given as a very small note in Lowell belly as well.
Yeah,
One thing I liked about Jaydeep was he was very calm and cool, which is very rare phenomenon in PG student. That is why his performance looked better than what probably he has done very well, but his performance looked very well, and he could perform better because of his, I'm not telling because he's from my institute, but his temperament was good. You can improve little bit of your rhythm, be little fast, that will give a better confidence level as well. That will show. Very well done.
Thank you.
Guru Shantapa sir, any closing comments, sir?
Like he said, yeah, he has done well and he is very, very calm and composed. Even though questions were at a higher level, but he could manage.
Yes. Well done.
Jaideep, all the best. You have done well.
Thank you.
So, sir, Kanna sir, can we call it a close, sir?
Thank you,
Yes.
sir. Thank
I
you.
think probably the most important thing, if it's a patient with Burzer's disease, is cessation of the smoking. That's probably the most important thing. Whatever you do for these patients, if these patients do not stop smoking, the disease is going to come back. Okay. So that's the most important thing. And before you go for any amputation, you should try to revascularize that as far as possible. Because you should not carry out the amputation without, if you carry out the amputation without revascularization, again, there'll be a further gangrene will be there. So it has to be revascularized, and which can be done either by the open technique or by the endovascular technique. And if it is like, if this patient comes out to be a localized block, which is there, definitely we like to go either for the endovascular technique, or you can go the open femoral-popliteal bypass here can be carried out. And always that should be done with the vein itself, not with the process. It should be done with the great saphenous vein, which is there, which is used for either the reverse vein is used or the in situ vein is used, and that gives a good flow to the blood. Thank you very much.
Thank you, sir. So with that, we call this session a close, and thank you, the invited faculty, Professor Vimal, Professor Guru Shantapa sir, and thank you to the PGs, Debashish and Jaideep. I think you did very well, and a good start for this year. And we also thank the scientific committee team, Dr. Kanna sir, Andarya sir, Rajiv sir, Shanai sir, and Srinivasan sir had to leave, and Andarya sir, everyone. Thank you so much. And we look forward for yet another event on 8th of January. Goodbye and good night.
Thank you, sir. Good night. Good night.
Thank you, Vimal sir. Thank you, Guru Shantapa sir.
Good night.